Meeting after a month of gap. Our gap was because of the hottest summer. Now we are in a hot summer, and of course, sooner we'll have 365 days. You want to say something? No. Their temperature is only 35 degrees. We are hotter than Europe. For them, 28 degrees also they call summer. Uh, there are many other places it's only 34. They can't stand that heat also. Our temperature is much. Gulf will be more hotter than us, or North India in summertime. So today I thought I went through some article where there is a discussion about oropharyngeal dysphagia, and I also joined Apollo Specialty. We increasingly see a lot of patients with oral pharyngeal dysphagia. Many of the things which is practiced there I never knew before joining there. I thought maybe I will bring some light to that. So the symptoms are choking, coughing. Anyway, Dr. Kavita is also going to discuss. The etiologies are neurological disorders, abnormalities, pharmacological, autoimmune diseases, age-related changes, and myasthenia. I tell you, myasthenia is one of the very difficult. In fact, there is a patient who went around all over Chennai, and in fact, they were coming to me for more than a month before I realized it's myasthenia, and we ended up doing a PEG, but patient didn't make it. So there are several diagnostic tests: video fluoroscopy, fiber optic endoscopic evaluation of swallowing, high resolution manometry, and a lot of treatment measures, dietary, nutritional support. Rehabilitation is one of the very important aspect of dysphagia management in oropharyngeal. Why should we manage this? It improves quality of life, protects airway, prevents malnutrition, and avoids tube dependency. It's a multifactorial team approach in which ENT surgeons, radiologists, neurologists, gastroenterologists, dietitians, and the center of it is a specialist who specializes in swallowing. Some students, what do you call specialists who practice swallowing? It's called deglutologists. They take pride in calling themselves as deglutologists. So clinicians' goal, long-term goal, oral diet and oral gratification. Short-term goal is rehabilitative strategies, compensatory, patient and family education, and if you increase the muscle strength in the pharynx and tongue, it improves changes in physiology, whereas compensatory mechanism doesn't improve muscle strength, but improves the swallowing immediately. Of course, there are several methods with food and without food. Compensatory techniques are posture, swallowing techniques, airway protection strategies, and diet, temperature, changes in diet, taste changes, rate and route of intake, and there are several prosthetic devices and many of them I don't know, it's not my purview, and I send patients to deglutologist. The need required depending on the different type of environment, whether they are in a single room with the therapist or in a target family gathering, cafe, restaurant. Techniques varies, and they try with saliva, thin liquid, thick liquid, texture modified food, and there are some patients who are fully dependent on supervised swallowing, whereas minimal assisted self-feeding is also common once they are rehabilitated. And then there are some exercises, and I have never seen this. So they raise, this is for strengthening the suprahyoid muscles, and sometimes they raise the head and hold it, thereby reduces the risk of aspiration. And supraglottic swallow focus primarily on preventing aspiration. They take a deep breath and hold it, swallow while holding your breath. So there the tongue role is very minimal, whereas I tried this, increasing the strength of posterior. It's quite effective. If they hold the tongue outside within the teeth and try to swallow it, then the posterior part of the tongue become active, and so of course expiratory muscle strength training is required to have a swallowing safety, improve the cough strength, and respiratory and voice outcome. And there are some neuromuscular electrical stimulation. Our declutologist practices that, and she says it gives immense. There are thermal tactile oral stimulation. They stimulate with ice cubes, lemon, honey, hot water, different part of the tongue cheek to have a good practice of swallowing. Key takeaways are: dysphagia require timely assessment. It's a multidisciplinary approach, ensures the best outcome based on evidence practice to have a safe swallow, and a patient-tailored approach is required with all combined modalities and constant motivation to patient. Thank you. I think I'll call the secretary to further.
Now we'll move on. I'll request chairpersons Dr. Shanmugnathan and Dr. S. Satyamurthy to come over and please conduct the proceedings, please.
Today's first session will be the panel discussion on approach to dysphagia, and will be a case-based discussion conducted by the moderator, Dr. S. Kavita, Senior Consultant, MGM Malar Hospitals. The panelists will be they can come on to they can take their chairs. Dr. Anil Kumar Chemili, Dr. Perarusu, C.V. Sheshadri, Dr. Hussain, and Dr. Ilanjayan. We can start the proceedings.
Good evening to all. First of all, I would like to thank the organizers who has given me the opportunity. So I would also thank Ravi sir for giving a lot of introduction on oropharyngeal dysphagia, which becomes nowadays most of the cases we gastroenterologists encounter with the oncology specialist, and in the post radiation therapy following an RT accidents, where we come across and how to handle them becoming more and more difficult. So first, on any cases, if you go having a dysphagia, so why we want to know whether it is a solid or liquid? Can I know? So we can be asking the question. Sorry, I don't know your names.
Introduce yourself.
Yeah.
Hello ma'am, I'm Dr. Hussain from SRM Hospital.
Okay.
I'm Dr. Anil from Meenakshi Medical College.
Hello ma'am, I'm Dr. Ilanjayan from M Hospital.
So all are final years or first years or second years? Second years. Okay. So first question goes to Anil. Why you want to ask whether the patient is having solid or liquid dysphagia? What is the significance of it? So it's more of interactive sessions. Please forgive me. My throat is very bad.
Because
Sir, I don't want to sing. No, welcome.
Because especially in case of esophageal dysphagia, whether it is a mechanical dysphagia or motor dysphagia. In motor dysphagia, the dysphagia will be initially to both solids and liquids, whereas in mechanical dysphagia, initially to the solids followed by liquids.
So it helps us
to classify.
Okay. What is the other name for mechanical dysphagia? Structural dysphagia. Any other name? So will you find out. Okay. So the liquid dysphagia will be either onset baby, neurological or a motility disorders. What common cause you are going to come across in Hussain in your practice? What are the motility disorders which you come across?
Most commonly, we come across achalasia cardia.
How many achalasia cardia you are seeing a month? What you are seeing most commonly in your day-to-day practice? Nowadays we are not seeing that much. Which motility disorders you are going to come across? Sir has been talking so much right now. Neurologists have never called you for dysphagia. Post-stroke related dysphagia. Why you think post-stroke related dysphagia? What is the common cause? Why post-stroke related dysphagia? What are the phases of swallowing? Anybody can elaborate? Anybody?
It will be under 4 phases: oral preparatory phase, and it will be transfer phase, pharyngeal phase, and esophageal phase.
Okay, what you are going to come across in post-stroke patient?
Especially in post-stroke patients, there will be deviation of the angle of mouth, so drooling of saliva will be there. So it will be difficult
What is
for
the nerve
making
supply
the
in
ball.
the tongue?
Hypoglossal nerve.
Then for the sensation, for the taste,
Glossopharyngeal will be there.
taste is glossopharyngeal or any other nerve?
Chordotympanic branch of facial nerve.
Huh? Which nerve is going to help in secretion of saliva? Why it is more important in post-stroke patient?
To
So
form
what
the
is the
bolus.
very difficulty for them? Risk of aspiration. Why? What is the problem they have?
It depends upon the cranial nerve involved in those patients who have stroke. In oral preparatory phase, if patient has paralysis of involvement of cranial nerve 7, then the patient will have an impaired taste, as well as the patient will have difficulty in preparing the food for transit, that is propulsion before.
So it is mostly a transfer dysphagia where you cannot transfer the bolus because the tongue is not rotating properly. So you are not having a breath holding properly, your pharynx is not going to close properly. So you are going to have, most of the time, we are going to have the dysphagia. So what will be in the course of dysphagia? When you come across an acute sudden dysphagia, foreign body, everyone will get the foreign body dysphagia, or any other pre-existing problem should be there for foreign body dysphagia? If it is going to be a large foreign body, it is okay. Otherwise, so web person will have what history they will tell you when you come across with a patient. So you are receiving a patient with dysphagia. He said he had a foreign body sensation. So what will be the first question? You want to exclude the web in the case? Huh?
He will have intermittent symptoms of dysphagia, ma'am.
Okay. Any other thing you will ask them very specifically?
Like if it is because of...
First question. What is the time taken to complete the food? What will be the time taken to complete the food? Usually? Normally. But in this patient, if they have web, it will be more longer. So the question should be asked whenever the patient comes to you with the dysphagia with the foreign body. We want to rule out any web is there. We want to ask what is the normal time taken for his to take his complete his food. If he is going to eat fast or slow, then if he is going to eat fast and coming with the dysphagia, it is mainly he is gulping a very large piece. That's totally different. Even a small, very small, even sometimes we have nowadays with Dolo 650 we have dysphagia. Anybody come across with it? When they try to swallow, and nowadays they started taking lot of Ayurvedic preparation and online preparation. Those tablets are very big. They doesn't know that's going to help them or not. They are trying to swallow and get stuck in the esophagus and they come to us. Suppose if the patient is having a progressive dysphagia, what are the differential diagnoses will come into your mind? So you come across lot of neurological always, the benign causes first. Whenever you present to anyone, which is the common cause you are going to see should be the first. Progressive dysphagia. So, anyone. So, see, don't get upset. So, we are making you to learn, nothing other than that. So, this will be your exam type. When you present your case, you may not expect these questions will be asked from the examiner.
Stricture, esophageal stricture, we can see progressive dysphagia. Malignancy also we can see. And in eclasia also we can see progressive dysphagia. And,
so, benign causes over.
Scleroderma also we can see progressive dysphagia.
Where do you come across intermittent dysphagia?
With webs and rings, especially intermittent.
Webs and rings. Then, what is underdiagnosed nowadays?
Eosinophilic esophagitis also.
Eosinophilic esophagitis. What is called non-progressive dysphagia? So, you should make a note of yours and find out whether you can use your cell phone and note all the questions, and you should give me the answers. I'm not going to say this, otherwise you'll never go back to read it. Okay, what is non-progressive dysphagia?
The dysphagia which is not progressing over long time, especially...
Not like that.
The progression of dysphagia, especially when it comes to the classification, the patient usually will have initially dysphagia to solids. If it's a patient has underlying structural cause, then it will gradually progress to semi-solid, liquid, as well as the patient not able to swallow, and the patient will have absolute dysphagia or aphasia.
How many times we are seeing absolute dysphagia? Don't tell anything which you don't come across in your life. Books may have lot of things, but what you do come across in your daily routine life will be your answers. How many times have you seen any absolute dysphagia? Yes, sir. Footballers get stuck. Sir, I want them to answer, sir. Please, sir. I want them to answer, sir. So, even in the benign case, we come across her because when the previous day when they have taken any bananas, any solid food of great size, get stuck, they doesn't know that it has been stuck. Sometimes they may have a pain or discomfort, but next day when they start to feed, they may find it difficult to swallow. Okay. So, what is the helping guidance for our duration of dysphagia? When there is a long duration, what will be the cause? When it is a short duration, what will be the cause?
Most of the motility disorders will have a long duration of the disease, and mechanical cause or structural cause will usually have a short duration of disease. And yes.
Okay. Can we localize the lesion?
Distal pathologies.
Easy to localize. Easy to localize.
Not easy to localize.
Okay, because patients say I have a discomfort here. He'll be thinking it is most of the time an epigastric discomfort. Sometimes they may say we have a sticky sensation in the retrosternal region, which is most of the time your mid-esophagus. Upper esophagus, automatically your hand goes there, tell that he is getting choked. So it is easy to locate until we gather the history properly. Okay, what are the additional symptoms do you love to ask when you have a patient with dysphagia?
Nasal regurgitation, aspiration, heartburn, regurgitation of food.
Okay. Where do you come across nasal regurgitation very commonly? Stroke. What? Next.
Myasthenia.
Myasthenia. How many cases have seen by myasthenia? I have not seen with myasthenia with dysphagia. Only Sarah has seen.
Patient with movement disorders like Parkinson's disease.
Parkinson's disease. Okay. Are you giving your opinion there? Have they called you? Or when they called you, you write simply patient is having a Parkinson's disease and don't come back. Then. So, what will be the common cause in eclasia? What will be the presentation? How the patient presents? Even before dysphagia. They say when I go to retire to bed, within 2 hours of my retirement of bed, I feel lot of secretions coming through the nose. That will be the commonest thing we are going to come across in eclasia. When you get the food is sticking in the mouth. In the mouth. Question be very clear. In the mouth. Xerostomia. Why? Anything
saliva.
why?
Less saliva.
Less saliva. So less saliva, how it is going to do?
In case of Sjogren's syndrome.
Why? so that you are not able to masticate and mix the food with the saliva to make it as a soft bolus. So patient says will have a dysphagia. Okay, pain during swallowing, when and all you'll get? Any? Pill esophagitis. Pill esophagitis. What pill esophagitis do you come across regularly?
Doxycycline,
Huh?
bisphosphonates, especially ortho bisphosphonates.
Bisphosphonates we don't come across that much, but what we see regularly?
Doxycycline.
No.
NSAIDs.
All your cardiac patients, give it to him. All your cardiac patients.
Aspirin.
Aspirin and clopidogrel. Nowadays, even the book says nothing with the clopidogrel. Even the patient presents with severe esophagitis because of clopidogrel. We are seeing nowadays a lot of cases. Even in the book, they say never say about Brilinta or anything, but still the patient is having esophagitis. Okay. Huh?
Odonophagia, like motility disorder.
Yeah, we'll come across. Yeah, in motility disorders, we don't come across pain. Patient will have only unable to drink the fluids, but we come across in one case a severe pain. In which case? Huh? Diffuse esophageal spasm. We don't come across much of the cases in our daily practice, but there are still. How the weight loss is going to significant? Always the weight loss will be benign or malignant?
It can be benign as well as malignant. It can be secondary to decreased food intake as well as loss of appetite by the patient, or with the primary course of disease like in malignancy as well as.
Okay. So what are the comorbidities you are supposed to take when you are seeing a case with dysphagia?
Diabetes mellitus.
Diabetic mellitus. Then
Hypertension.
hypertension. How we are going to connect with this dysphagia? Anything we are going to connect with dysphagia?
Yeah, if he is using calcium channel blockers,
Huh?
more regurgitation.
Okay, then any cardiac illness, then we come across lot of patients with asthma. You are never telling it. They present nowadays with dysphagia. Why? Because of atopy as well as eosinophilic esophagitis as well as with your candidiasis. Okay. What medication is really going to help us to help in our dysphagia? Huh? Calcium channel blockers. In the comorbidities, you are supposed to examine the patient even for scleroderma if they are having any rheumatoid arthritis. What is the mnemonic? Scleroderma with dysphagia. Rest expanded.
Calcinosis cutis, Raynaud's phenomenon, telangiectasia and esophageal dysmorphia.
Yeah. So a small case nugget which Sir was describing a lot. I thought in the last minute we have added this. This is a 65-year-old male present with a history of Parkinson's disease, present with initiating the difficulty in swallows and having a coughing and choking while drinking liquids alone, and have a hoarseness of voice. Symptom occurs immediately within a second of swallowing. He also had a nasal regurgitation and recurrent aspiration pneumonia. What is the common cause in Parkinson's?
The symptom has occurred within 1 second of swallowing, which indicates dysphagia occurs secondary to defect in the transfer phase, or it particularly
mainly a
the
transfer
oropharyngeal.
dysphagia. How you want to counsel the patient? They called you for dysphagia. How you want to counsel this patient? What and all initially we can try? So you can ask whether the patient is on Syndopa, ask make the food ready and take the Syndopa and within 10 minutes to swallow, so his motor activity will be very good, so that you can prevent dysphagia. If he is not, he is on Ropac and not on Syndopa, then it may be very difficult. In such a case, you should ask him to take a mixy ground semi-solid food always, not a liquid, because in liquids he regurgitate. And nowadays they start, as Sir said, the deglutologists say, chin tuck maneuver. Anybody heard of it, chin tuck maneuver? So you want to project your face and do it like this and try to swallow, so that it enters directly into your esophagus. So it helps in preventing a choking. Always the patient should sit erect and not in 60° and 45°, which we do in most of our elderly patient who is sick. We make them lie down and spoon feed, nothing works. Okay. So how will you differentiate esophageal dysphagia from oropharyngeal dysphagia? I hope Sir has put a lot of slides over it.
Oropharyngeal dysphagia has dysphagia occurs in the first second, associated with nasal regurgitation, aspiration, and choking.
Esophageal dysphagia.
Will have a food stuck-like sensation as well as foreign body sensation, as well as patient will have associated.
Foreign body sensation. How many times have you come across? How many patient told you? Dysphagia, there is no foreign body sensation. If there is a foreign body sensation, then come, what is global sensation? Is a patient can eat normally in a global sensation or not? Why?
Because there will be no any object obstruction. It is only patient will have symptom feeling of sensation, but there will be no feeling.
Yeah. So nowadays the dysphagia is called as swallowing dysfunction. See, nowadays in the dysphagia they have divided into safe and effective transfer. Safe is for oropharyngeal transfer and esophageal dysphagia is a transfer. So impact safe and effective transfer of the bolus from the mouth to the esophagus is called oropharyngeal dysphagia, whereas esophageal dysphagia is swallowing is generally perceived. They try to swallow, then the problem rises. So it is related to either the lower esophageal sphincter, any stricture, any webs and those things. So it may most of the time may be associated with your anatomical causes, functional or mechanical causes. So you know the treatments available. So we'll go for the next case. This is a 23-year-old male. He's a college student. He complains of difficulty in swallowing for the last 6 months, and he also has an associated abdominal pain. Both started at the same time. He has a progressive dysphagia, initially for solids, and now even for the liquids within the last 1 month. He had an unintentional weight loss, and the epigastric pain is get relieved by taking food after some time. What other history you want to ask in this case? What do you think in this case?
History of heartburn.
History of heartburn. The patient is not having any heartburns. We have told one word. Eosinophilic esophagitis regarding intermittent dysphagia, because many a time they may not have dysphagia, they will be having intermittent dysphagia. So only they always neglect, they know how to act smart. So what are the differential diagnoses with this history you want to come across? So this patient is an young male with 6 months history of difficulty in swallowing with dysphagia with unintentional weight loss. What are the differential diagnoses will come into mind. What will be a order of your priority? Hussain?
Peptic stricture.
Peptic stricture. So he didn't tell anything before that. There is no epigastric, this only abdominal pain. There is no regurgitation as I told you. Do you still want the peptic stricture to be the first one? Next.
Achalasia also we can keep in mind.
Achalasia also we can keep it in mind. Okay. Next.
Eosinophilic esophagitis.
Eosinophilic esophagitis. Okay. So what is a classical symptom of reflux disease? How the patient will tell the classical symptom of reflux disease?
So after eating, they will feel like the food is returning back, as well as food comes up to the mouth or up to the nose. It depends upon the
How
degree
many minutes
of
later?
Uh,
Or any specific? Or any position related? Position related.
It will be more on supine position rather than in sitting posture.
Okay.
Okay.
Okay. How many times you ask this history to the patient when they come with your GERD? Because you people simply take a history, write a medicine and send them across. And you miss the case. Anytime have you asked in your practice? So what will be the, if you tell it is a GERD, this symptom should be there. What is the symptom should be there if it is a GERD? The patient should always have the retrosternal discomfort. then only we can label it them is a patient is having a GERD. What other history do you love to ask them if it is a GERD? The patient per se will tell you, when I gets up in the morning, he'll start like this. So what will be the history? Anyone?
Patient will have recurrent sore throat complaint.
Sore throat, voice change, any other?
Dry cough.
Dry cough. Then what is called acid brush? So you never ask in your practice. See, many a time the patient will tell us clearly, I have a sore toast in the morning when I get up from the bed. It's always says he comes up with the esophageal reflection. How many tires are there to look after your lower esophageal sphincters? Sorry, sir, tappu. How many tires are there? 3 tires. நான் உங்களுக்கு கிடையாதுன்னு சொல்லிட்டேன், உங்களுக்கு நான் தனியாக கேட்குறேன். How many tires are there? Have you read across? Because you people neglect this lesson. It's a third lesson in your esophageal chapter. We'll give 3 tires. Nobody reads it, but examiner loves it. So every question of this dysphagia comes only from that 6 pages. All this time what we have discussed is everything in that. So please go and look into it. So what is your favoring diagnosis in this case? What are the points favoring a motility disorder? List out.
Age.
Age. Another one symptom we told.
6 months of duration.
Yes. Then one question you asked me, I told is patient is having an intermittent dysphagia. So more for liquids than for solids. Okay. On clinical examination, this patient was moderately built, but he was lying comfortably. What signifies it? What we are ruling out now?
Echalacia is ruled out because here fundus is fit with.
I have asked only history. I didn't ask you to look at the picture. Lying comfortably. So you are ruling out echalacia because he is not having a nasal regurgitation. He is not having a GERD because he is not having any retrosternal discomfort. His BMI is around 23.3. At heart rate is 78. And otherwise normal. His chest X-ray is normal. The barium swallow shows this picture. Can anyone describe it? Elangerin.
So the lower end of the esophagus, you can see a regular looking filling defect.
Regular looking esophagus. Then patient is having dysphagia. மேலெல்லாம் ஒன்றும் தெரியல சார், கீழே தான் தெரியுது. கீழே கண்ணுக்கு தெரியலனா. So what you have seen, there is a constriction. What it signifies? Either it may be a ring, either it may be a peptic stricture. Okay. So the benign strictures is always a smoothly tapering. It's always a concentric narrowing. Maybe affect on one side first and then progress to the next side. The malignant strictures are always having an abrupt, asymmetrical in nature and irregular in nature. They may have a tapered margin. Do you have any tapered margin in this? No. So it is a benign stricture. Okay. So this is the endoscopy finding. Who want to describe it? Sheshadri.
Like erythematous and edematous mucosa with luminal narrowing is there.
You have, I couldn't look at any erythematous. I couldn't look any edematous.
With luminal narrowing.
Only luminal narrowing is there. So what are the things comes in your mind? What will be the first thing coming in your mind having this?
Stricture.
Stricture. What type of stricture? Benign or malignant?
It is like smooth, looking like smooth margin.
So it is always a benign stricture. How do you differentiate between benign stricture and malignant stricture?
Like malignant stricture, the borders will be like irregular borders will be there. And
malignant stricture, regular borders?
Irregular.
Irregular borders.
Irregular borders. And the surface of surface will not be smooth and it will be puckered. And there are chances of ulceration and fungating will be there if it is.
Okay. So the benign stricture usually scarring because of your chronic acid exposure or either your prior surgeries or caustic injuries, whereas like malignant strictures are mostly your squamous cell carcinoma, and the development is slowly over month due to inflammation in case of benign strictures, whereas the malignant strictures will be rapidly progressing. The visual appearance of your benign stricture is clean and smooth, as you said, and irregular margins with nodules and ulceration, whereas with malignant strictures, the symptoms are always slow in onset with difficulty in swallowing, with history of heartburns are very common in case of benign strictures, whereas in the malignant strictures, it's a rapid onset swallowing difficulty with severe unintended weight loss. How do you want to treat your benign stricture? What is the first thing you want to do before you proceed for your benign stricture? Patient is having unintentional weight loss, everything. Do you go for dilatation first, or do you want to do something else before doing your dilatation?
We have to, in a patient is a young male, so before going further, we have to rule out any malignant cause for this.
Malignant cause. Do you look in this case any malignancy? Are you looking at your
no, until we have to evaluate the cause for stricture, ma'am.
So do you want to make the patient wait for 3 days for dilatation once you come across the patient?
As it has,
what can be done?
Patient has 6 months of dysphagia, maybe his nutritional will be different, ma'am. So we should check for hemoglobin, and we should correct whether if hemoglobin is low before dilatation.
First, I want to do on the table you have diagnosed there is a benign stricture. What will be your next step? Huh?
At the same time, we can.
You want to dilate it, or you want to do some other thing before your dilatation? No investigation. They are only decision.
Biopsy, we have to.
They are only decision first. I am not telling about biopsy. Should I dilate or not? What should be my decision? So, do you all have pediatric scopes with your department? I believe. Why can't you use it and look into the deeper section? Why you want to look down before dilatation? See, when we practice, we don't have. We straight away dilate it. Then only we remember all those things. But nowadays, since it is available, what you want to look at?
To rule out complex.
Whether it is a complex stricture or a simple stricture. If it is going to be a simple stricture, what you are going to do? You are going to dilate. Sometimes even take a biopsy to rule out malignancy. So what are the difference between your simple stricture and complex stricture? How do you differentiate?
Simple is less than 2 centimeter. Complex is more than 2 centimeter. The diameter will be more than 12 millimeter in simple, while less than 12 in complex. And,
what is the normal AP diameter of your esophagus?
AP is 2 centimeter, while transverse is 3 centimeter.
3 centimeter. Okay. When the patient will develop dysphagia?
Less than 13 millimeter.
Less than 13 millimeter. Okay. So, you are the simple stricture usually less than 2 centimeter, and whereas the complex stricture it will be more than 2 centimeter. The shape will be always straight in a case of simple stricture, whereas the complex stricture will be angulation or tortuous. The luminal diameter is always less than 10 to 12 in a case of simple strictures. In the complex stricture it may still be lower down. Endoscope passage is possible because sometimes we can rotate your scope. What is your scope? Which scope do you use? Olympus. What is the outer diameter of your upper esophagus?
9 mm.
9 mm. What is the therapeutic endoscope diameter? 1.2. What are so you never looked into it. You didn't expect these questions. So you should always be ready for your therapeutic scope so that only we know. See, nowadays we use the diagnostic scope itself for therapeutic most of the time because of your unavailability. But when it is available, we are going to do with only your therapeutic scopes. Okay. So responsible for dilatation, if it is going to be benign structure, a single setup is enough, or do you want recurrent to make it? Most of the time it may be a single dilatation may help, but you want to ask the patient to come for follow-up whether they are going to have again. But in the case of complex strictures, sometimes most of the time patient may need a recurrent stricture and multiple sessions. So common cause of your stricture in case of benign lesion either may be Schatzki ring. What are the types of Schatzki's ring? Perarasu.
Schatzki A, B will be there.
No comments. What is A, what is B?
Schatzki A will be just above the OG junction. And it's almost circumferential. Schatzki B is a semicircumferential.
Semicircumferential. How many times do you see when you do your endoscope what you will do if you do the Scott-Kiss ring? Do you dilate or you wait, or what will you tell your patient? See, many times we see the Scott-Kiss ring. Do you dilate or you wait? Wait. Why? Huh? Until the patient is going to develop a symptom of dysphagia. But you should tell the patient quietly that you have a ring, it may progress in near future, so that keep in account, don't try to swallow a big food, because you may land up in acute absolute dysphagia, as Ravi sir told us. Okay, so that should be kept in mind. So what is refractory stricture?
If you are unable to dilate to 15 mm after 5 successful sessions, 2 weeks
How
apart.
many time you will take between each session?
2 weeks, 2 weeks.
2 weeks. So almost at the end of 3 months, if you are not able to success, we are going to call it as a refractory stricture. So it may be when it is a long segment stricture or a tortuous strictures, it may be refractory, or sometimes even a short stricture which is having an angulation and tortuous will still have, yes. So they may be, if it is going to be a long stricture, it may be an ideal candidate for. Nowadays, what are the things available for this long segment stricture to dilate?
Boozy type dilators will be here.
We have done 10 times. தெய்வமே சார் உங்களுக்கு இதை 3 தடவை ப்ராம்ப்ட் கொடுத்துட்டாரு. செம்ஸ், வாட் இஸ் த டைப் ஆஃப் செம்ஸ்? என்ன செம்ஸ் போட போகிறேன்? படிப்போமா? ஸோ வாட் இஸ் த டைப் ஆஃப் செம்ஸ்? எல்லார்கிட்டையும் ஆன்சர் கேட்பேன். நான் மற்றவங்க மாதிரி கிடையாது. கண்டிப்பாக நீ ஆன்சர் கொடுக்கலன்னா நான் உனக்கு ஃபோன் பண்ணிடுவேன். So all questions should be kept in mind. Either you can note in your cell phone, anything you can do, but I need answer always.
3 types are available. There are self-expanding metallic stent, self-expanding plastic stent, and biodegradable.
Okay, which you want to place it?
For refractory stricture.
For refractory stricture. So you are going to read and tell us. Okay. So sometimes the patient have, whether if they are willing for surgical, we can go for surgical, or radiation if it is going to be a malignant stricture which is not, we are proving it, then you can go for radiation. Sometimes you can use steroids over your balloon for dilatation. What steroid do you use?
Triamcinolone.
Triamcinolone. Okay, how it helps?
It will inhibit this collagen formation, whether it will inhibit that.
Which cell division it inhibits?
This transforming growth factor beta.
Mitotic cell division of the cell. Okay, so we want to find out whether it is a caustic or other etiologies. Accordingly, we are going to dilate. Suppose covered sems should be always placed when you are not able to success at the end of 8 to 12 weeks. If it fails, no other success, we should project them for surgery. What is the surgery called? I am telling surgery. What is the surgery? If it is going to be the lower esophagus, if it is going to be the mid esophagus. Lower esophagus, what surgery? If it is a mid esophagus, what is the surgery?
Ivor Lewis and McHugh once, but Ivor Lewis for lower esophagus and McHugh once for mid esophagus.
Okay, but most of the time our surgeons are very smart, they pull the stomach. But what is the complication we get crossing?
Patient will have
lot of refluxes. Okay, the next case. 40-year-old female presented with symptoms began 3 years ago and now recently worsened. Her dysphagia was to solids and then liquids almost every meal. She describes a sensation of food or liquid stacking up in my esophagus. Some episodes of dysphagia are associated with mild substernal discomfort, and she tried to walk around, raise her chin, move her shoulders backward in an attempt to alleviate her discomfort. She has a rare episodes of nocturnal and oral regurgitation, denies her weight loss, GI bleeding or heartburns, and does not use any alcohol or tobacco. She was on levothyroxine for hypothyroidism. There is no other medical history and no family history of GI cancers. She denies any seasonal allergies. What is the differential diagnosis coming into your mind?
Esophageal dysphagia, possibility of motility disorders such as
motility disorders. Okay, then. In motility disorders, do you feel the food or liquid stacking up in my esophagus? A clear cut point tells you. So we'll go through. So what are the most likely etiology with this history? We have given the options. We have given the clue also in the next question.
Primary eclasia.
So Anil Kumar.
Can be primary eclasia.
Primary eclasia. But I never said that the patient is having nasal regurgitation. I never said no. You didn't look into the history properly. Choose one man. For that also find it difficult. Then how can I proceed? So first priority. Every clue they have given you, man. Okay. So we'll tell you, sir, eosinophilic esophagitis. What are the compensatory behaviors? Who is going to tell me? So we'll ask Perarasu. What are the compensatory behaviors of eosinophilic esophagitis? Any mnemonic?
Elimination, right?
You thought simple dysphagia will be discussed here. Huh? So it is called impact behaviors. So imbibing a large amount of liquid with meals, modify your food into small impact into pieces, prolonged and repeated chewing make it more successful to make a small kind, avoidance of any dry or tough food, and chewing excessively. Turn away from the food entirely leads to reduced diet. So the compensatory behaviors we call it as impact behavior. Okay. So who is going to describe me the esophagus endoscopy finding? So we'll ask Perarasu. We have given all the picture. What and all you are seeing, you can tell us. Is the esophagus is normal or not in this case? Normal. Not.
Almost.
What it is not normal? What you are able to see? Huh? Tracheal rings are where? I am not able to see any tracheal rings. That is duodenum. I want to make you confused, man. Huh? I am very clever than you.
Edema and erythema
Huh?
we can see.
Edema.
Yeah,
I never
erythema.
see any edema.
Furrows, longitudinal furrows.
Where is furrows?
B.
B is linear furrows. Okay. C is actually duodenum to make you confused. I know. You fall into it.
And here
G. G.
monilial.
Okay. Tell me the typical feature of eosinophilic esophagitis endoscopic findings.
Ring-like appearances.
Ring-like appearance.
Edema, erythema will be there.
Edema, erythema.
And
Then.
furrows.
Then.
Furrows.
Which is the proper definition for it? Parchment paper with white exudates. So the esophageal mucosa often demonstrates the characteristic features of rings or trachealization. Have you any time come across this trachealization even in your normal patient when you are taking your endoscope very slowly?
Tertiary.
Have you come across? Yes. So the concentric rings will be seen. Furrows, the longitudinal linear furrows or exudates like white specks. See, we have seen in the last picture the white specks, but you forgot to mention it. So white specks are plaques representing eosinophilic microabscesses, strictures narrowing of the esophageal lumen. Up to 30% of the cases may present with endoscopically normal esophagus and underscoring need the biopsies. So how you want to take the biopsy? You have a suspicion of eosinophilic esophagitis, but still you're not able to come to a conclusion. How many biopsies you need? From where and all you should take it?
The biopsies
are needed.
6 biopsies or 6 places? 6 biopsies from where? Noting down 6 biopsies is not a matter for me. Where and all you want to take?
414.
அதுக்கு தான் சார் வெயிட் பண்ணிட்டு இருக்கேன். அவங்க யாரும் என்ன சொல்ல மாட்டேங்கிறாங்க. அவங்க dysphagia காம்ப்ளெக்ஸாக படிச்சுட்டு வந்துட்டாங்க.
414.
So you always should give a trial of PPA as said. How many days? How many days?
2 weeks.
2 weeks or 21 days. You are supposed to give for unintentional dyspepsia. You need to give always 3 weeks of PPA whether the patient is going to improve. If not going to improve, once you stop the drug again the patient is going to develop a dyspepsia. You are going to see the patient and take a biopsy from where and all. Duodenum. Then our case is esophagus. You are telling me duodenum. Anyway, okay, duodenum. Then mid esophagus.
14 and the 4.
Usually it should be an upper and lower esophagus. Why?
Will be
Why upper and lower esophagus? How will be the eosinophilic distribution? It is always in a patchy manner. Different segment at different levels. So we need an upper esophagus, a lower esophagus, your fundus, your antrum and your duodenum and your body. Everywhere you are going to take. Okay, you have taken. So describe the picture now. Anyone know to describe or doesn't know to describe? We'll skip on, no harm. At least you should tell me what is ABC or DEF and GHI. Okay, how the esophagus musculature is made up of? How many parts you are going to divide your esophagus? Upper, middle and lower. What is the musculature in your upper esophagus? What is in the middle? What is in the lower?
Striated muscle fibers
Where?
in upper esophagus and mixed muscle fibers will be in there. Mid esophagus and lower almost half smooth muscles will be there.
How many layers are there in the esophagus right now?
4 layers, mucosa,
4 layers.
submucosa,
Okay. So if the first ABC is your upper esophagus showing some amount of microabscess, and the middle is the lower esophagus having a large microabscess with lot of eosinophils. How many eosinophils will be normally present in patient normal biopsy from OGJ junction? How is eosinophils are present in OGJ junction? Yes. How much? How many? 5 to 6. If it is going to call, you are going to call it as an esophagitis eosinophilic. More than 15 to 20 you should take into account nowadays. The lower one is your fundus biopsy of your stomach biopsy, where clearly signifies your glands and with lot of eosinophilic deposits under your glands, saying that even if the patient is having a eosinophilic gastritis. So histopathology requires 15 eosinophils per hypuff field. The biopsy should be taken from both distal and proximal esophagus due to patchy nature of the disease. The diagnostic difficulty is the clinical symptoms of esophageal dysfunction. Eosinophils are predominant even in inflammation. Exclusion of other causes of eosinophilia, especially GERD, PPA and responsive eosinophilia. See, at least you should take 8 gastric and 4 duodenal biopsies. How many eosinophils should be there in duodenum to tell it is an eosinophilic duodenitis? More than 52. When will it call it as eosinophilic gastritis? More than 40 eosinophils. Okay, how we want to manage this case? So management will be like Sheshadri Miyot Hospital. What and all investigation do you want to add on this? Because I never tell about any investigation. I am talking only like a Kudevalam Katina Kudurai towards gastro. So what and all added investigation you want to ask in this patient before you are proceeding for your treatment?
Absolute eosinophil count. Right?
Absolute eosinophil. What is a normal eosinophil count?
Like less than 6% of total MBBS.
Less than?
6%.
Sorry, if I am going to have 13,400? I want the number. Normally it should be less than 400. Eosinophil count. Okay, then what and all you want to, because patient denies one history. Just keep on specifying it. She denies her allergies. So how do you want to prove that the patient is having an allergy?
Serum IgE levels.
Okay, what is the normal IgE level? 20. See, what we see, then only we inculcate. Until we don't think, we don't see it. So what is the normal level? It should be less than 150. In this patient, we always have more than 300. Then, any atopy. You want to examine them in the total to look for the extensor surfaces, to look for any eczemas, any atopy at an young age, any milk allergy, everything should be asked into account. At any point of time we are asking in our OPDs? No time, madam. See, your GERD is your bread and butter. Any time of any people, so you should be in and out about your GERD. So how will you want to manage this patient? So we have given all the clues. So now, what are the 3 Ds? Given the clues. So always the 3D concept of drugs, diet and dilatation. The first we are going to do is a pharmacological with swallowing corticosteroids, either a cortisone propionate or budesonide. Do you want to ask him to swallow? Or do you want to do something with budesonide tablet? Huh? Just swallow. Crush. And what to do? Crush panna powder idam. But enakku smooth coat aite ponume. Otherwise my work is not going to happen. Huh? Chew and swallow. Varadu.
Mix in water.
Huh? So you want to crush it, mix with either the sucralfate gel nicely, make it a smooth mixture, ask them to eat like ice cream. Don't ask them to swallow very immediately. You will not get your result. Okay? So patient should take very slowly, imbibely, meduva, romba meduva, they should take swallow, so that only it coats the entire esophagus to help in your action. Okay? So empirical elimination of diet, same 6 food map diet you can eliminate, or whatever you want, whichever he is coming across, because some people may have an allergy to something and something, so we can ask them to make a diet diary and find out their difficulty in eating, because patient denies no. So when you ask you write your diet diary, you should tell them when and all they find it difficult in swallowing should also be noted across it, so to be noted. So the dilatation, endoscopic esophageal dilatation will be there. So what are the clinical mimics? Only these 2 questions. What are the clinical mimics and histological mimics? He told me close my chapter. I have 2 more cases we'll discuss later. So you are going to tell me what are the 4 clinical mimics and histological mimics in your answer sheets. Okay? Thank you, sir. So let me go for the last 1 slide alone. Sorry for taking you long time. So any patient presenting with dysphagia, so you should ask for swallowing including choking and nasal regurgitation, any food stops or stucks, whether it is a solid or liquid food, find out whether it is a mechanical or structural. If it is a mechanical, whether it is a progressive or intermittent. If it is going to be a progressive, you should rule out whether it is a peptic stricture or a carcinoma if it is an elderly male. And if it is going to be an intermittent stricture, you are going to think about your lower esophageal ring. And the neuromuscular disorders, if anything, whether it is a progressive or intermittent. So chronic heartburns and respiratory symptoms should always taken into account, which I didn't come across because in the next few cases we had. So rule out your scleroderma and achalasia. If it is going to have an intermittent chest pain, otherwise fine in between, it may be a diffuse esophageal spasm. Thank you.
Exhaustive, actually very nice discussion for the PGs, very nicely presented. I think when you become an external, it will be very tough for the PGs, I think. So we didn't cross the symptomatology at all.
We are trained by Mohammed Ali sir and Jayanti madam. I used to present madam exam cases from her hometown.
Yeah.
So she taught me a lot. And Mohammed Ali sir, who taught us. Each case discussion will go for 2.5 hours. The credit goes to him. Thank you.
I'm sure all the PGs will be benefited. Extensively detailedly presentation of the symptomatology and how to approach a case. Actually, this panel discussion is very important because you are going to deal day to day in practice, and you have a patient there in front of you, then how to go about it. So the pattern of PG discussion is very good actually. We also learned a lot. We have also brushed up our DM period. So next, thank you, ma'am.
Thank you.
And thank you all the panelists. PG students, you also performed well. Okay. So next we go on to the journal of this month. So I call upon Dr. Ram Anjaneya Reddy from SRMC. We have the review of the recent publications in the field of luminal disorders from India. Over to you.
Good evening, everyone. Today I am going to review the recent publications from India in the topic of luminal disorders. So today I am going to discuss about 8 articles published in the last 3-4 months. So first one is about the prevalence, clinical significance and predictors of small intestine bacterial overgrowth and elevated FCP in refractory IBS patients. So why this study? Mainly the authors quoted that the clinical problem of symptoms of SIBO overlap significantly with IBS in like bloating, diarrhea, abdominal pain and flatulence. So and SIBO may be misdiagnosed as IBS, and SIBO patients have elevated FCP and evidence of low-grade intestinal inflammation. So the current knowledge gap is about prevalence and significance of SIBO and elevated FCP in refractory IBS patients. So the study objectives were, primary objective was to determine the prevalence of SIBO in refractory IBS, and secondary objectives was to determine prevalence of elevated FCP, assess relationship between SIBO and FCP, and evaluate impact of symptom severity and identify the predictors of SIBO. So design was, it was a prospective study, cross-sectional and analytical study. Location, it was done in Dayanand Medical College in Ludhiana, and it was done in adult population after 8 years, or like whoever crossed 18 years of age. And inclusion criteria was Rome 4 IBS with refractory symptoms despite more than 6 months of standard treatment. All the patients who had recent antibiotics or probiotics intake and IBD, microscopic colitis and celiac disease or prior GI surgery history were excluded from the study. So coming to the definition of refractory IBS, persistence of symptoms despite antispasmodic, antidiarrheals and bulking agents, standard IBS therapy for at least 6 months. So in this study, total 209 patients were initially screened. Out of these, 36 patients were excluded, and out of the remaining 173 patients were diagnosed as IBS, refractory IBS patients. So 25 were excluded with again because of either recent history of antibiotics, probiotics or underlying past history of GI surgery and all. So finally 148 patients were selected for this study. Among this cohort, again the subdivided IBS types. Of this, 105 patients had IBS D type and 28 patients IBS C type, and mixed type is 15 patients. So after the analysis, so they have done 2 tests. One is quantitative fecal calprotectin, and another one is glucose hydrogen breath test. Overall SIBO prevalence was 31%, and that was significantly more in IBS D subset, and elevated FCP was noted in 27.7% of the patients. So there was a strong overlap between SIBO positivity and elevated FCP, especially in IBS D subset. So the clinical significance of this study was SIBO and FCP positive patients will have a longer duration, longer disease duration, greater symptom burden and more bloating and higher inflammatory markers like CRP or FCP. So the clinical implications from this study is like refractory IBS patients get a glucose hydrogen breath test done, get a FCP. If SIBO is positive, treat them with rifaximin and target microbiome therapies. If elevated FCP, these authors did not mention particularly about the anti-inflammatory therapies, but they mentioned that there is a chance of potential future anti-inflammatory therapies. But the limitations of this study, sir, it is cross-sectional, and GHBT was done instead of jejunal aspirate culture, and only hydrogen breath test was done instead of, they did not include a methane test, and this is a single tertiary center, referral bias is a possibility. So take home message, nearly 1/3 of the refractory IBS patients have SIBO, and nearly 1/3 patients have elevated FCP. IBS-D is the phenotype most strongly associated with both, and SIBO positive patients have worse symptoms and poor quality of life. Now coming to the second article, this was published in March 2026. The article is about, is Clostridium difficile superinfection a major causative factor for acute flares associated with moderate to severe ulcerative colitis in northern India. So usually EZ is characterized by recurrent episodes of disease activity. Flares may begin occur due to natural disease progression, infectious triggers and drug related factors. C. difficile infection matters because it can mimic flare symptoms. It is associated with increased hospitalization, higher colectomy rates and increased mortality. The study objectives were, primary objective was to determine the prevalence of C. difficile infection in hospitalized patients presenting with moderate to severe UC. Secondary objective was to assess relationship with prior antibiotic exposure, evaluate clinical outcomes of CDI positive patients and compare Indian data with global prevalence. So study is, again, it is a prospective observational single tertiary care center. Location, it is done in Medanta, Gurgaon, and duration was from May 2023 to May 2024. It's a 13-month study. Inclusion criteria was previously diagnosed UC patients who had again presented with acute flare, recurring hospitalization, moderate or severe disease by Trulovitz criteria. Mild UC cases were excluded from this study. All these patients were tested for C. difficile infection within 24 hours of admission. They tested for both GDH and C. difficile, both the toxins. Diagnosis is only considered positive, both GDH and either of these toxin is positive. So out of the patients included in the study. So yeah, so coming to this, these are baseline characteristics of the patient. Prior antibiotic use was within the 8 weeks was noted in only 12 patients, and prior biologicals was noted in 17 patients. And median duration of the symptom was 6 days during this flare, and median duration of the total disease burden was 30 months. So out of the 140 patients evaluated, only 6 tested positive for GDH. Out of these 6, only 4 had both toxins also positive. So the overall prevalence came up to only 2.9%. So CDI positive patients, like only 4 patients, all had severe UC. 3 of them were female and positive within 24 hours of admission. Sigmoidoscopy was done in all the patients. No pseudomembranes was observed. Outcomes was uneventful recovery in all the patients. So prior antibiotic exposure is noted. Totally exposed patients, like 12 patients. Among the CDI patients, 2 out of the 4 patients had prior antibiotic exposure. Of these, they had cephalosporins exposure in 11 out of 12 patients. Statistical significance, antibiotic exposure is significantly associated with C. difficile infection. So the final conclusion was C. difficile prevalence among the moderate to severe UC flares was only 2.9%. Whereas reported global prevalence in C. difficile infection in IPD patients was around 8.8%. Asian data shows 11%. C. difficile infection does not appear to be a major causative factors for acute flares in northern India. Most patients have favorable outcomes with prompt treatment. Larger multi-center studies are required. Again, limitation single center study, limited sample size. The third article, it's done in AIIMS Rishikesh, which published in March 2026. So this article is about using mastic gum as an adjunct therapy to the standard bismuth quadrupole therapy for H. pylori infection eradication, a randomized single-blind pilot study. So why mastic gum? Why the authors consider this? Because this potential mechanism is the bactericidal activity and anti-inflammatory effects, including inhibition of neutrophil activating protein from the plant Pistacia lenticus, the mastic tree. The resin is collected. The study objectives were: primary objective, assess whether adding mastic gum to the bismuth quadrupole therapy improves H. pylori eradication. Secondary objectives to assess the dyspepsia symptom severity index and adverse events and treatment compliance. Study design: single center randomized placebo controlled pilot study done from January 2024 to March 2025. Inclusion was 18 to 16 years, treatment naive H. pylori patients and positive rapid urease patients were considered. Exclusion was patients who had prior history of H. pylori eradication, recent antibiotic use, pregnancy or lactation, or major systemic illnesses. So, in the intervention arm, 2 groups were there. So one is group A with standard therapy with mastic gum, 500 mg capsules twice daily. And the second group had 32 patients, only the standard therapy. The BQT regimen used was bismuth 120 QID, metronidazole 400 TID, and tetracycline 500 mg QID, along with omeprazole 20 mg BD. Duration was for 14 days. So the primary endpoint was negative urease breath test at 6 weeks. Secondary endpoint was dyspeptic symptom severity index improvement and any adverse events recorded. So out of the 1 or 2 patients screened, only like the final 64 patients were taken for the study. So out of these completed patients were 26 in the first arm and 24 patients in the second arm. So this is the outcome. The patients in the mastic gum with the standard therapy, they had negative urease breath test in 85% of the patients, whereas positivity was seen in 15% of the patients in this, and BQT alone had only 67%. Even though there is a numerical significance, I mean like numerical superiority in the first term of mastic gum with bismuth quadruple therapy, but there was no statistical significance. So, but however, the mastic gum arm showed overall improvement in the dyspeptic symptom severity improvement and dysmotility symptoms improvement along with the reflex symptoms improvement. The strength of the studies was the first Indian RCT evaluating the mastic gum plus BQT and randomized controlled design. Limitations, it is a pilot study, small sample, again single center, single blinded, and 22% attrition, and no antibiotic susceptibility testing was done in either of the patients group. Now coming to the next study, this is actually a study from the US but published in Indian Journal of Gastroenterology in May 2026. Comparative effectiveness of mirikizumab and risankizumab in patients with ulcerative colitis in propensity matched cohort study. The primary objective of this study was to compare mirikizumab and risankizumab and risk of corticosteroid use within 180 days. Secondary outcomes they measured was therapy change, colectomy rates, or any FCP response or safety outcomes. Study design, again it is a retrospective cohort study, and study period was from October 2023 to May 2025. Method is 1:1 propensity score matching, where they have retrospectively matched the study population into controls. They matched for the age, comorbidity, sex, and all everything. So inclusion criteria, 18 eligible patients more than 18 years of age, confirmed UC, initiated on mirikizumab or risankizumab, exclusion or Crohn's disease, psoriatic arthritis or previous colectomy rate. Treatment regimen used was mirikizumab 300 mg IV followed by weeks 048, and maintenance therapy is at 200 mg subcutaneous every 4 weeks. Risankizumab was 1200 mg IV at weeks 048 and maintenance dose is 360 mg subcutaneous every 8 weeks. This is the final result of this study. In the left side, we can clearly see the purple color is the mirikizumab effect and the green is the risankizumab. Mirikizumab associated with lower hazard ratio of corticosteroid use within 180 days of the drug usage. And in the right side, we can see mirikizumab is associated with higher proportion of FCP. I mean, like mirikizumab showed better control of FCP compared to the risankizumab. The strength was first head-to-head real-world comparison. Large multinational database was used. Propensity score matching was done, and strength was first head-to-head real-world comparison. And same thing is repeated. And conclusion is mirikizumab was associated with lower corticosteroid use, better FCP normalization, greatest benefits in biologic exposed patients, and no difference in colectomy or therapy change was noted. Now coming to the next study, this is done in published in March 2026, done in AIIMS, New Delhi. A single test strategy using spot fecal bile acid test may be feasible strategy for the diagnosis of bile acid malabsorption. So existing diagnostic tests for bile acid malabsorption is gold standard is selenium HCAT test. But the limitations is it has radiation exposure, expensive and limited availability, because where the patients are asked to swallow a capsule containing selenium HCAT, and they are observed for after 7 days of the percentage of retention. And other tests available are serum C4 and serum FGF19, 48-hour fecal bile acid estimation test. So the primary objective of this study was to determine the optimal fecal bile acid cutoff for the diagnosis of bile acid malabsorption, and secondary objectives was to estimate prevalence of bile acid malabsorption in IBSD and functional diarrhea or post-cholecystectomy patients, Crohn's or TB patients. So design was, again, it's a pilot observational study, cross-sectional AIIMS New Delhi, done in 2022-2023. Positive controls were ileal Crohn's disease patients and negative controls were healthy patients. So in this is the flow chart. I mean, like the baseline characteristics of the patients, how they characterize things. So initially they shortlisted 132 healthy controls. Out of this, excluded 32 patients, and finally they considered 100 controls. And post-cholecystectomy status 100 patients, and interstitial TB patients was in 33 patients. So now coming to the results of this study, we can see the average. I mean, like, this is the first healthy controls group. The median fecal bile acid measured in these patients was 1.5 micromole per gram of the stool. Ileal Crohn's disease patients, it is around 6, and IBS-D of the patients 2.0, and post-cholecystectomy patients, it is 3.4. Intestinal TB 3.0. So using statistical analysis made up of a cutoff of 2.8 micromole per gram. So using this cutoff, ileal Crohn's disease patients had 59. Proportion of the patients with more than 2.8 was 58. That is 88.1% of the patients in ileal Crohn's disease had a positive from this test, and healthy patients are only 8% positive, and TB patients 54.5%, and this 57% in post-cholecystectomy patients. The clinical implications in the low resource settings, single stool fecal bile acid test may screen bile acid malabsorption, reduce the need for radiation exposure and difficult to access test, and identify the candidates for bile acid supplementation therapy. Particularly useful in IBS-D patients, functional diarrhea, post-cholecystectomy diarrhea, and ileal disease. But the major limitation is they did not compare this fecal spot test with standard selenium HCAT comparison. But ileal Crohn's disease is used as a surrogate and a standard for positive controls. It's a single center study. Actual validation is required for this study. Now coming to the next study, this is published in March 2026. Implementing key quality performance metrics improves colorectal adenoma detection, evidence from India. So this is done in Sai Institute of Gastroenterology from Bhubaneswar. So objective of this study was to evaluate impact of standardized quality focused withdrawal technique ADR in a real world Indian practice. Single center observational study from September 2022 to August 2024. So the control arm was the control arm had they considered the patient retrospective data from September 2022 to August 2023. So total 3 endoscopies were involved in this retrospective data, and with 3 to 15 years of experience. Interventional arm was the patients from September 2023 to August 2024, whoever had undergone a colonoscopy. It was done by a single endoscopist. Standardized protocol was followed. So now what the author says is quality focused colonoscopic practices are like thorough mucosal cleaning and suctioning, adequate luminal distension, careful inspection behind folds and around flexures, right colon retroflexion, rectal retroflexion, emphasis on adequate withdrawal time in accordance with the guideline recommendations, and complete documentation of key quality indicators including bowel preparation scores, cecal intubation, lesion morphology, and use of enhanced imaging when appropriate. So out of 20 to 60 patients, so intervention arm was given to 1265, and control arm had 995 patients. Indications for the colonoscopy was altered bowel habits, pain or bloating, GI bleed or anemia. So now coming to the results, this is the control arm and this is the intervention arm. Control arm, the average withdrawal time was around 3.6 minutes, whereas in the intervention arm, the average withdrawal time was 8.7 minutes. Polyp detection rate was seen in only 11% in the control arm, whereas 32% in the intervention arm. Adenoma detection rate was 6.3% versus 20%. However, no significant difference in the colorectal carcinoma detection rate. So comparison with the global or Asian data, global adenoma detection rate was around 8 to 35%. China, Japan and Korean cohort showed 24 to 35% detection. Prior Indian retrospective study showed 2.1 to 5.4% of detection. So the strength of this study was the first Indian study to prospectively demonstrate quality driven ADR improvement, same center, same time period, and video recorded withdrawal times were there. However, the limitations were there in this study. So confounding factors by operator differences, because 3 endoscopies were there in control arm. Incomplete lesion level histopathology for the control arm because it was a retrospective data. And single center, single intervention arm operator, limited generalizability. Clinical implications are standard withdrawal protocol, more than 6 minutes, systemic inspection, retroflexion is feasible, and reproducible even in high volume, unsedated Indian practice. Now coming to the next study, this is published in June 2026. The study is from AIG. Impact of timing of pre-medication on mucosal visibility during endoscopy, a randomized control trial. So the primary aim of this study was to determine the optimal interval between administration of simethicone with N-acetyl-16 and upper GI endoscopy for achieving adequate gastric mucosal visibility. So it is a prospective single-center double-blinded RCT done from February to April 2025. Inclusion was age more than 18 years, elective diagnostic endoscopy was done, excluded all the emergency patients or active GI bleeders who were presented with dysphagia or previous gastric surgery were excluded from the study. So total 1,580 patients were considered. Out of these 380 were excluded, either it can be because of decline to participate or did not meet the inclusion criteria. So total finalized 1,200 patients. Out of these 1,200 patients, they divided them into 4 groups. The first group is the placebo group. Placebo group is basically they have done with less than 10 minutes, and this thing second group is after administering the simethicone and N-acetyl-16. Timing for the endoscopy is 10 to 20 minutes. The third arm is 20 to 30 minutes, and the fourth arm is more than 30 minutes. So they have graded mucosal visibility scoring. They are measured in 4 regions. One is in antrum, second one is in distal body, proximal body, and fundus. The scores per region was 1 is clean mucosa, 4 is heavy mucus. So total score ranges from 4 to 16. So they consider adequate visibility is score less than 7. The primary outcome was adequate gastric mucosal visibility, that is a score less than 7. So secondary outcome was total score, regional visibility, flushing requirements, and lesion detection rates. So out of the patients after analysis, this is the placebo arm, which had only score less than 7. Only 2.7% of the patients had this. The better scores were seen in patients in third and fourth arm, that is patients after 20 to 30 minutes and more than 30 minutes had 64% and 67% of better mucosal visibility when compared to the other groups. And this is the overall average median score in the different arms. As we can see here, after 30 minutes, once the score is around 6, and again the fourth arm, more than 30 minutes, they have divided into 3 subtypes: more than 30 to 50 minutes, more than 50 minutes, and more than 70 minutes. As the time increases, we can see the gastric mucosal visibility is decreasing and score is increasing. So what the order is suggesting here is, after ROC analysis, so optimal timing for simethicone administration and endoscopy should be around 25 minutes. So the limitations of this study was single center study, visibility score not formally validated, small numbers beyond 50 to 70 minute interval were included in this study. Conclusion was simethicone with the NAC significantly improves gastric mucosal visibility. Benefit is time dependent. Optimal visibility achieved between 20 to 50 minutes. Effect begins around 25 minutes. And this is the next study. This is about gut colonization with multi-drug resistant organisms in hospitalized patients with gastrointestinal illness, a single center cross-sectional study done from AIIMS, New Delhi. The primary objective of this study was to determine prevalence of gut MD, multi-drug resistant organism colonization in hospitalized patients who are admitted in GI ward. Secondary objective was to determine prevalence of antimicrobial resistance genes, assess factors associated with colonization, and evaluate concordance between rectal swab and clinical cultures. A design was single center cross-sectional AIIMS, New Delhi, done in October to November 2022. 18 to 75 years of patients were included, admit more than 48 hours, and ward or ICU. The sample size is around 107. Sample collection: single rectal swab was from each patient was collected within 24 hours of admission. Early morning sample was collected and it was sent to the lab, and it was stored around -80 degrees. And from the baseline analysis, antibiotic use history was noted in around 90% of the patients. They are tested for antibiotic resistance. NDM antibiotic associated resistance was seen in around 65% of the patients. The primary outcomes was near universal gut colonization with multi-drug resistant organisms in hospitalized GI patients. So out of these, like 106 out of 107 had MDR organisms. High prevalence of carbapinamase producing organisms. So out of the organisms profile, most common was E. coli, followed by Klebsiella and Enterococcus species. Resistance more than 75% of most commonly used antibiotics was noted. Breast preserved activity, I mean like the less drug resistance was noted in tizicycline, there is only 3% resistance was noted, and colistin 6% and linezolid 10%. Outcomes, overall mortality was noted in 26.2% of the patients. Mortality according to again colonization, isolated gut MDR was mortality was there in 22%, whereas gut plus clinical sample multi-drug resistance organisms was there in 50%. Major limitations of this study was basically again single center, smaller sample size, cross-sectional design, cannot distinguish between community acquired infection versus hospital acquired infection, no multivariable analysis. Again the patients were considered in this group were very sick patients, referral bias. Clinical implications for gastroenterologists was hospitalized GA patients are heavily colonized with multi-drug organisms. NDM mediated resistance is highly prevalent. Empiric antibiotic selection should be considered, local antimicrobial resistance epidemiology, enhance infectious control mechanisms and follow antibiotic stewardships. Future directions, multi-center studies, longitudinal surveillance and meta-analysis. Thank you.
Fashioning the jaw line, and then of course H. pylori, but several indications for that, but for one purpose they say it is very useful. Patients who have people halitosis, and if they have sulfur hydrogen sulfide producing organism in the mouth, the chewing mastic gum is very useful. Rest of other thing is only that is what I read in recent one science latest science book.
Where it is available, sir?
It is very much available in Amazon. If you put mastic gum, it will come. Suggest are you using for jawline fashioning? Are you using for H. pylori? What is it? Everything is coming. I don't know the cost. I think 3,000. It is available as resin, available as powder. So many preparations are there. No, absolutely. It doesn't have side effect. It is a plant resin. Whether it has an effect is the question. People make side effect is loss of money.
But according to the study, the BQT arm had a eradication rate of only 60%. That is less, no, compared.
Statistical significance was not there between the two arms. What the other told was maybe because of the lower sample, statistical significance was not there. So they suggested high multi-center analysis.
And the mastic gum arm had a 85%.
I have a question for Dr. Jain. See, these bacteria protect themselves against the effect of acid by the mucus. Suppose if we use mucolytic agent before antibiotic in, will it be more effective?
You'll have to, I do not know, because you need the time for it to act, no? For the mucolytic, whatever agent you're giving. So most of these studies, and that bile acid study, I was one of the reviewers. So it went backward and forward for almost 6 months, It's not an easy paper the way you analyzed it. Your intestinal tuberculosis, Crohn's ileitis, all of them have a high bile acid. So you cannot explain that. When you see that chart, it was very difficult to convince, and that bile acid assay is not available. It was pharma mediated. They got it for the study, and that's the end of that. As of now, it's not there in the market. That paper went almost for 6 to 9 months, it went backward and forward. Very difficult paper to understand. And because it was from AIMS, they pushed it for a publication. We were forced to accept it that way.
So currently the only way to diagnose bile acid diarrhea is response to treatment. If you in India, it is in most of the world, that is the only way you can diagnose bile acid.
Yes. Thank you. Thank the chairpersons and all the presenters. We had an interesting postgraduate session. Now we will move on to the CME part. Before that, I have my duty to present my secretary report. So, start off this month. Okay. So again, congratulations and hearty wishes on superannuation to Dr. Kandaswamy Kumar. I think he's retiring after a glorious service for last more than 3 decades. I think this month he's retiring, and we wish him well in the forthcoming years in his practice. The HCC epidemiology, the study is still in the data analysis phase. It has been compiled. It's still going through the analysis. They had to write it up. The GERD study that was proposed by Dr. Illavarsi, there are some improvements that has been suggested, and they are still not yet finalized. It's in the study design phase. So we'll be moving on with probably in the next month. Hopefully we will get the final study design. We'll again go through the committee to see how whether it suits best. I'll request all the trainees who have come in to again fill up your student membership form of Tamil Nadu ISG. It's available online. So henceforth we'll request we will make it mandatory for you to furnish your membership number as well, and also enroll as members of the national body also. So forthcoming meetings, our midterm meeting in Tamil Nadu ISG midterm meeting will be at Madurai on 17th and 18th of October. And the annual meeting will be in Chennai. It will be on 30th and 31st of the month end of Jan 2027. The Endocon is coming up on 28th to 30th August at New Delhi. And the WCOG is from 30th September to 3rd October. So this will be hosted in a combination with ISG, WGO, INSL, Crohn's Colitis Foundation, India Pancreas Club. So it is at the Ash Bhumi, and the ISG organizing committee had earlier sent repeated reminders to avail the early bird registration. Right now the routine registration is ongoing, and they request all members to register for the WCOG meeting. Right now it is at 34,000 plus 18% GST. So request all members to kindly consider who is planning to participate in the WCOG. So I'll request the President to come around and discuss about the ISGCon 2027, please.
So I'm very glad to announce that the ISG National Conference for 2027 is awarded to Tamil Nadu. So we have hardly 1 year, 1.5 years. We have a lot of work to do. We need to sit often and form the committees. Dates we haven't fixed. We want to have it in. There is a time there won't be, the heat is appropriate, and the rain won't be there. So maybe we should have a meeting exclusively for discussing. Dr. KRP was there behind all this, getting it for Tamil Nadu. He is not there today. Maybe coming weeks he will come, and then we'll discuss that. Who is the organizing secretary? So we applied with Dr. Ubal Das as organizing secretary for the conference. Rest of the committee members, we will meet and discuss and form. Okay, thank you.
Nothing much to add. I think it is not an individual effort. I think it is mainly we struggled for last few years from the days of Ravi, and when I was secretary, we are trying to organize this conference for so many years. This I don't think anybody's applied, so that's the reason I think they give to Chennai this year, because we have very short time. Usually ISGCon, usually there will be a 2 years period, but we have almost less than 1 year to plan things, and we started some initial efforts, and maybe as Ravi said, we have to discuss among ourselves and put various committees. And my main intention is, because last few years of ISG, there is not much crowd inside the halls. Most of the people is attending on the outside activities. Our main intention is to make the scientific program more interesting and to keep the audience inside the hall. That is our main motto of conference. And maybe we need to work more on it, and subsequently we'll discuss further about the dates and other things. Thank you.
Thank you. So I again request all the attendees to please scan the QR code in your desk and fill up your attendance form. With that, we will move to the second part of the CME, that's on fatty liver. I request the chairpersons, Dr. B. Padmanabhan sir and Dr. A. R. Venkatraman, to please to come over and conduct the proceedings. We'll have a topic for lecture followed by a panel discussion. I request the chairpersons to take over, please. Thank you.
Hello. The first chapter talk is by Dr. Vijay Alexander from CMC Vellore. How do alcohol and macel interact? We are going through some of the articles. So macel to metal to ALD. That is, he is going to elaborate on this point. Alcohol is interesting. Macel is also interesting. Whether they have a symbiotic or parasitic or anything going beyond the continuum. Over to Vijay Alexander.
Good evening, everyone. Thank you to TNISG, Brahma sir, and everybody here for this opportunity to present a talk on MET-ALD. So over the next few minutes, I'll try and keep it interesting. There's quite a bit of theory, but we'll try and quickly go through some data as well. So I've titled it as Navigating the Intersect Between Metabolic and Alcohol-Related Liver Disease. And MET-ALD is relatively a new terminology, at least, though people have been talking about how alcohol and metabolic liver disease, or MASLD or NAFLD as it used to be called before, used to interact and how it has a synergistic effect. One disclosure is that I've used Notebook LM to create some aid visualization. So how the terminology has evolved over time is NAFLD was in vogue up until very recently. Then briefly there was a period where people referred to as MAFLD. I'm not even sure if MAFLD caught on. And then MASLD as we call it now. And then around 2023 is when MET-ALD was first formally called MET-ALD, and all bodies have approved the use of this terminology now. So what really did bringing the term MET-ALD mean for diagnosis or for physicians like all of us? What it really did was, what was so characteristic about, what is so peculiar about NAFLD was that it was a diagnosis of exclusion, and then came MASLD, where it was a more inclusive diagnosis, where you could have other contributing factors, but the predominant thing was metabolic liver disease. And then replacing two entities, and to say that there's something in between, and what is referred, I'm not sure you can see the cursor. Okay, never mind. So to say that there is an entity called MET-ALD, which is in between MASLD and alcohol-related liver disease. So we'll go into MET-ALD in detail over the next few slides. So first is to come up with a diagnostic criteria. Second is to define alcohol thresholds for making a diagnosis of MET-ALD, and what is the requirement for metabolic dysfunction. So before we start, I just want you all to just think about how, or rather, if we are all comfortable making a diagnosis of MET-ALD, and how often have we actually written in our charts or in our electronic medical reports that this patient has MET-ALD. So I'm not sure too many people use that term, but I think it is important to make this diagnosis and make this distinction, and we will come to why this is important. Okay, so this is probably the most important slide from my this short presentation. Very important to try and get an accurate estimate of alcohol intake in each patient. Very difficult, very cumbersome. I know we all try and we fail very often, but if we actually have to honestly make a diagnosis of MET-ALD, we will have to come up with an alcohol threshold for each disease. So on the left we have MASLD, where it is 140 and 210 grams per week for women and men respectively. For alcohol, it is more than 350 and 420, that's for women and men, and again that's per week. And in between, we have Met-ALD zone. So that's 140 to 350 to 10 to 420. So these numbers may be more important for exams, but also good to remember while we see these patients in OPD. Now, what is the caveat here? Standard drink definitions do vary globally, and we are all aware of that. UK is 8 and US is 14. So there is this broad umbrella term of steatotic liver disease. This is again, so 2023 is when this particular classification came into being, at least in this particular format. So on the left we have MASLD. I'm sorry that my cursor is not seen. Okay. Sure. So on the left side we have MASLD, and on the right side we have alcohol-associated liver disease or alcohol-related liver disease, ARLD as many people call it. And here we have the alcohol thresholds for making each diagnosis. In between we have 210 and 280 grams per week. Here we have 20, 30, 40, 50, 60. So always important to remember these thresholds are different for men and women. Okay, so now that we have said where Met-ALD falls, important to remember, important to sort of look at how common these things are. So this is, most of these data unfortunately comes from Western literature. We really don't have systematically analyzed community level studies which have been done looking at steatotic liver disease from India at least. So this is an important paper, but this is, mind you, this is from the United States. Important to remember, they have looked at age-adjusted prevalence of steatotic liver disease in the community from their survey, NHANES survey. We keep hearing about this in multiple survey-based studies. So the entire prevalence of Met-ALD was about 37%. So 1 in 3 Americans have steatotic liver disease. In that, 32 is MASLD, and about under 3% is what actually fulfills this Met-ALD. But this was a survey-based reporting, and this is self-reported intake of alcohol. Again, pretty much similar data from the American cohort. It's just another publication, similar numbers. So we have about 34% of steatotic liver disease and about 3% of Met-ALD. Now, what was important in this particular study was, as opposed to what we are going to see later, is Met-ALD associated with increased risk of poor outcomes in liver disease. This particular study said that significant fibrosis was about 20% in MASLD and 13% in Met-ALD. Advanced fibrosis was 9% and 5.5%. So Met-ALD, according to this particular data, didn't really have terrible outcomes as compared to MASLD. Again, another important slide which has looked at geographical differences in Met-ALD. So we have Asia here, which is 8%, Europe 2%, Latin America 3%, and North America 2.4%. So again, how reliable are these data, how representative it is for our setting, we will have to look at it. But as of now, available data says that Asia does have probably the highest Met-ALD rates as compared to the rest of the world. So what is the pathobiology of Met-ALD? It's not rocket science. It's we have two risk factors. If you have hepatitis B and alcohol, or hepatitis C and hepatitis B, the damage that goes on in the liver is going to be much more than what individually each of these risk factors would cause. Similarly, if you have metabolic liver disease and you have coexistent alcohol, you are likely to end up with a lot more damage. Now, what is the magnitude of this damage is what we need to try and understand. So before we go on to understanding how this interacts, one very important, now I did not really think of it this way, and I read this only now when I was preparing for this presentation. Alcohol itself can contribute to hypertension, hypertriglyceridemia, hyperglycemia, all of which are metabolic risk factors in making a diagnosis of MASLD. So one risk factor being present, and if there is significant alcohol, always be cautious in making a diagnosis of Met-ALD, because alcohol itself can be the driver of that. Having said that, is it really important? It's more for disease classification and terminology rather than for what it would really mean to the patient. So we have a synergistic attributable risk. I will skip this slide. Important question, how much alcohol is harmful? So there was previous recommendations that said, okay, a little bit of alcohol is probably okay, beneficial. Over time, this thinking is slowly changing. This is from GBD data, which said as the number of standard drinks go up, the weighted relative risk of alcohol for different outcomes. In fact, we have looked, this GBD data has looked at mortality, this looked at all adverse outcomes, generally tends to go up, and that's what this graph is showing. So, is there a safe limit of alcohol? The answer is probably no from recent evidence. All right. Now, how are we going to make a clinical assessment? Very important to try and at least get an accurate alcohol assessment. We may not really achieve that due to multiple reasons, the most common of which is underreporting. How often do we have patients being very forthcoming with the data, so or the information on how much they drink? Every time you ask, one drink once a week will then become every day, will then become multiple drinks every day. Then if you keep prodding a little bit more, it can then become they start drinking from morning. So underreporting, poor reliability when it is self-reported is all a problem in getting this. We do have validated questionnaires. Now if the information provider is honest enough, then we can go by that. We do have biomarkers. Now this is being used more and more. We will skip all of this. So as I said, challenges in quantifying alcohol use is a real problem. Now I did not come across this in literature, but one personal opinion is that if we keep questioning, we can only go by what the patient or the patient party is saying, and if we keep questioning that and we appear like we don't believe what they're saying, it sort of affects our rapport with the patient as well, and it can become a barrier in us delivering any meaningful treatment to that patient. So it's important to find that sweet spot and that balance when we are trying to elicit a reliable history of alcohol as well. So they are actually vulnerable, and they are presenting a big vulnerability in front of us. It's a disease, so we have to be sensitive to that as well while we are trying to achieve this. One of the biggest barriers in trying to assess proper alcohol intake history would be time for the doctor. How willing are we to sit and actually figure out the grams of alcohol that a patient is taking? I don't think most of us are willing to spend that amount of time. All right. Last concept in trying to assess alcohol intake is a longitudinal assessment would make more sense than a one-time assessment as assessment for any parameter. Why? Because we may start with pure alcoholic liver disease. They may over time tend to fall into MetALD phenotype, and over time, say years from abstinence, you may also end up with an almost pure MASLD phenotype. So important to sort of have a longitudinal assessment, not just go with a one-time label which was done 10 years back. I said there are alcohol biomarkers. This used to be just an MCQ or more of a theory before. Not anymore. There's increasing interest in biomarkers for picking up alcohol-related liver disease, especially phosphatidylethanol. In the UK, before listing, PET level is mandatory before they list and proceed with the transplant. And in fact, it needs to be done serially, and it has to be done prior to transplant as well. In fact, they can be rejected an organ if they have a high PET level, which then suggests that they have been there has been ongoing alcohol intake. So we do have cutoffs. I don't think it's so important to know, but this is where MetALD falls. Very high values will sort of point towards alcohol being the sole etiology. In between is MetALD and less than 20. 20Y, that is the level of detection set by the company which makes the kit. So it makes the assessment a bit more objective. So it's good. Can you have false positives? I'm not too sure of the answer. I hope not, because the range seems quite high. All right, so we do have this recap table. We will skip this. When in doubt, biopsy can be quite useful. So we do have all the hallmark features of alcoholic liver disease, severe alcoholic hepatitis, and when these are not there, we can probably inch more towards calling it MASLD. Right. Where are our challenges? Fluctuating alcohol intake. We all know nobody is going to be drinking the exact same amount of alcohol throughout consistently. Like any activity, alcohol intake is fluctuant as well. Misclassification from the physician side, the hepatologist side, the gastroenterologist side, and because of poor reporting from the patient side is a real problem. Also important to remember, like we said, longitudinal assessment is required. It is a dynamic disease phenotype and not a one-time assessment. Okay. Last portion of the talk, does MET-ALD carry a poor prognosis as compared to alcoholic liver disease or MASLD in isolation? Alright. So first of the studies, in fact it's a 2010 study. Nobody called it MET-ALD at that point of time, but people did look at these two risk factors. So they looked at components of metabolic syndrome in patients with alcohol-related liver disease. So population-based study, so that is the biggest strength of the study. They found that 44.5% of patients with alcohol-related liver disease are obese, and 1 in 3 patients with alcohol-related liver disease do fulfill criteria for metabolic syndrome. So definitely coexistent. So what? They found that metabolic dysfunction outcomes worsen, dysfunction worsens outcomes in alcoholic liver disease itself. So if you see the overall mortality in type 2 diabetes being a risk factor was 3, insulin resistance was 3.21, and then obesity was 1.58, metabolic syndrome was 2.37, liver related mortality and cardiovascular mortality. So they all seem to go together. Metabolic syndrome doubles the risk of liver related mortality in alcoholic liver disease. So definitely poor outcomes as per this study. Second study, again population based study. This is an English cohort which looked at obese people consuming quite a bit of alcohol. So they had about 20 times higher liver related mortality than normal weight men. So again synergistic effects in both. So here we have the baseline risk. Here you have the baseline risk with BMI. This is relative risk for death and adverse outcomes. Here we have baseline plus alcohol. This is all two together. And then they have quantified the interaction between alcohol and obesity and given it the dark blue. So definitely it's not additive. It's a lot more than additive. Similar findings from another study where they again said moderate alcohol drinkers with metabolic syndrome has a high 10-year risk. So this was looked at prospectively and over a period of time. Do genetic risk factors for obesity like PNPLA3, variant mutation, alcohol intake and obesity work together? Yes. So the answer is yes. They found that risk of cirrhosis, hepatocellular carcinoma and mortality was significantly higher if they had all three as compared to people had one each. So excess alcohol intake, you have the odds of cirrhosis, HCC and liver related death, and you can see it goes up. Diabetes, and when you have the mutation, definitely HCC and liver related mortality was higher. Interesting slide where the 10-year liver related mortality, if you have excessive drinking, obesity and homozygous carrier of the variant, see how much more 10-year mortality is compared to each risk factor being alone. Right. So that I am sort of at the rear end of my presentation. How do we manage these patients? So I really don't want to get into management. The next session is on pharmacotherapy in MASLD, but very important to look at the patient as a whole. We are not dealing with alcohol alone or MASLD alone. Very often than not, we do have a combination of the two, try and categorize them properly, and then we take care of the metabolic management and we try and take care of the alcohol abstinence and alcohol related liver disease as well. I think an important part of this would be to empower ourselves in managing the metabolic part of the patient as well, and not relying too much on endocrinology or other specialties. So we should be confident in managing a good part of the metabolic part of the problems as well, which can increase patient acceptance, and they would be happier to see one doctor than 15 doctors. Controversies: are these alcohol thresholds appropriate? Nobody knows, but this is based on what came from a Delphi consensus. So over time we will know if this is better, or 10 years later somebody else will say some better thresholds are there. Should biomarkers replace self-report at the cost of patient repo and mistrust? So we don't know the answer yet, but biomarkers do have a role. Is it a distinct disease or continuum? So this is probably the only one I have an answer to. It's probably more of a continuum than a distinct disease. And a lot of future trials will, over time, it's being increasingly recognized and people will diagnose it more. So MET-ALD recognizes the overlap between metabolic dysfunction and alcohol-related liver disease. We can attempt to try and estimate alcohol assessment as much as possible. We may or may not succeed in this, but let's be hopeful and empower ourselves to jot it down every time we see a patient. It's more synergistic, it's not additive, so the risk sort of tends to be exponential rather than additive. A longitudinal assessment whenever possible should be done. We all tend to see these patients more than once, so we should go back to this history every time. Weight gain has to be asked every time, whenever we remember. Management must address both metabolic risk factors and alcohol exposure. So that's the end of my presentation. Thank you.
Chairpersons, can I make an observation? Vijay, excellent talk.
Thank you, sir.
I think you guys are dealing much more in this than most of us here. But then we have also started making this diagnosis of MET-ALD based on the questionnaires which we have.
Sure.
If we are cage positive and then all that we try to. But it's a very thin line.
Yeah.
And we don't know whether it's really alcohol contributing or whether it's metabolic contributing.
No, that's true.
Except for the abstinence, I think the treatment is the same.
Yeah.
I don't think there's much change between the two except for the abstinence. But that interesting point that PET level has to be done to probably prioritize. But how does it help in management?
In terms of, I know it sort of helps us to categorize classically.
Categorize that, but how does it help in Does it help in management? But is it easily available? But
if abstinence is an absolute must for certain things, then it helps us to put into a box rather than otherwise management. Probably it's not enough. I mean the assessment in terms of abstinence and reiterating that abstinence therapy, all of that may need to be looked at more. Honestly, I don't know the answer to that, sir, but I'm guessing it is not to be looked at in isolation. It's one extra information that we have to sort of make the picture complete. Yeah.
Yep.
Talk on moderate alcoholism and severe alcoholism. How do you categorize the patients?
The first one will be to get a reliable intake in terms of grams of alcohol, sir, where we are going to find difficulty, especially when there are local brews and things like that, where we don't even know what the content of alcohol is. So we'll only have to go by a guesstimate and we will have to go by that. So categorization in fact is difficult. There is one study from AIG where they tried to do it, Dr. Mithun Sharma's paper, but very, very difficult in real life. I agree with you. Sorry, sir. Absolutely. Insurance is also, yes ma'am, also.
When I don't know how many of them have calculated, when this paper came, when I calculated, it was like, it was like of 210 grams, which is equivalent to 2218 ml. I feel most of patients never drink more than that.
Yeah.
And the similar way, the BR is about 15 cans, where it is also not crossed for the females when they go across for 1 week. The brandy, it comes around 660 ml, and many a time it is not crossing. Then, do we want to standardize ourselves? Whether our metabolic parameters are totally different when compared to the other people? Should we go across it?
Ma'am, I think, thank you for the question. I think we should categorize. Whether we put this label or not is a different question, but in fact, we all know in our population, cardiovascular outcomes and all-cause mortality is more for the amount of alcohol we take and with the risk factors we have. So our risk is much higher. So
Yeah, when we go to the patient and asking them the history, even the attenders, they say very, very less. It's very difficult to quantify. But patient says, I never consume. Then the friends come and say, no, madam, hardly he drinks twice a week. But the progression of the disease is very rapid. And they have an early hypertension and the obesity, which was started in their way back in the earlier age. So nowadays, when I start doing my fatty liver study, I do come across the pediatric age group. Since I practice both pediatric and the adult, we do come across a lot of my obese pediatric patients are hypertensive at the very young age. But it's very difficult for us to tell them to start the drugs or to reduce the weight. They feel reluctant. And the parents say, I'm like that. So how should you change?
I agree with you. I do not know the answer to that, but at the end of the day, over time, I think multiple visits may make a lot of the therapy we deliver, I think, depends on the rapport we have with the patient. So beyond broad categories and labels, I think there's personalized medicine for everybody, and we will have to look at that at the end of the day. I agree with you. Yeah.
Patient is very sick, they come out with it. Minus that, you'll never get the history. We have this ICOM, the consortium that's on. We don't get that. They, in fact, they leave that question blank. They don't answer that question. But when they're very sick, alcoholic, severe alcoholic hepatitis, they come out. This is amount I'm drinking. So I think that history is, you will never get it. And insurance always comes in the way. So we're not able to identify, Some of us put it as M for our own identification. Yes, he's taking alcohol. But we're not able to quantify that at all.
Or put a label in our diagnosis.
Somewhere, at least I have some identification mark to say if that's the mark, then he's taking alcohol. So that doesn't come in the insurance.
One small observation. It is a continuum. Recent article in 2026 May, it is a continuum. There is a definite meta-LD. When you see, they studied 7-8 months in Italy, they say mast LD is stable. Meta-LD, they can go to ALD with more drinking, or they'll go to mast LD type. So ALD can change to even mast LD 10%. So mast LD is the most stable group actually. So when you have mast LD with 20 grams of the alcohol group, the low risk, we have a green group, yellow group and the red group. So that means the mast LD has to be tackled more. The alcohol has to be good for abstinence. One simple calculation we used in brandy in Chennai and Tamil Nadu, we divide by 3. They say quarter cutting half full. When you divide by 3, 90 minus 90 divided by 30 grams. It's very easy sometimes. You can't say for weight by volume 44%, that's difficult. Divide by 3, get a value, approximate value. So, some people do also hospital ethyl glucose in air and urine. That is it only experimental, recreational, or it's in the clinical practice?
There are, I think it is available more as I'm not sure it is, it may be available commercially, sir, but not I've also read it as theory. It is definitely there, and there is some time difference in how much they tend to persist. Definitely hair lasts longer, and I think it's about a few days to, I'm not exactly sure, but I presented only data on PET.
Sir, in
Thank you.
Does the degree of elevation in the biomarker level correlate with the quantity of alcohol taken?
So there's some data to suggest that, not conclusively used as yet, but that this was actually based on one prospective study, this one, where they set ranges for more than 200 is purely due to alcohol, and in between there's some alcohol intake that goes. So more than 200 is definitely the significant alcohol intake. But I'm not sure I can stand by this. Can there be false positives? Possibly. But we'll probably have to have more data, especially from India, to back that. But there's some evidence to say that.
As for the quantity of alcohol taken, just on the lighter side, after a few drinks, people don't remember how many more alcohol drinks they have taken.
True. All are challenging, so I agree.
In your
yeah.
So in your presentation, there was a slide which showed that the amount of fibrosis in MET-ALD was lower than ASL. So do we take it that in MET-ALD, the more dangerous component is the absence of alcohol would be lesser when compared to control of, say, the metabolic parameters?
In fact, that was just one paper which said that, sir. Generally, all other data generally tends to say that MET-ALD seems to do worse than MASLD alone. So I think the combination is probably worse than pure MASLD. Thank you. Thank you.
Thank you very much, sir. It's quite interesting topic. We also have another interesting topic. Moderator Dr. Ashish Goyal, how to choose pharmacotherapy for NFLD. Shall I call the panelists? Dr. K. Prem Kumar, Professor of Hepatology, Madras Medical College. Dr. Radhika Venugopal, Senior Consultant, Department of Hepatology, Rela Hospital. Dr. Ashwin Krishna, Senior Consultant, Department of Hepatology, Apollo Hospitals. Dr. U.V.U. Vamsidhar Reddy, Senior Consultant, Department of Hepatology, Kaveri Hospitals. Dr. Varun Kumar, Assistant Professor, Department of Endocrinology, CMC, Vellore. Thank you. Dr. Ashish Goyal will proceed.
Thank you to the Tamil Nadu ISG for this opportunity. Let me congratulate Dr. Ubal and the entire Tamil Nadu ISG for this remarkable achievement to get the 2027 ISG Con. So we look forward to that and a great responsibility on all of us. Maybe next 30 minutes or so we will discuss, and let me just say that I haven't shared the slides with any of you, so sorry for that, but I will keep it as simple as possible. So how do we choose drugs? And we will learn all together. We don't have correct answers most of the time, and Dr. Varun is there from endocrinology to give us that perspective as well for metabolic disorders. So let's see. In initial few slides would be why not to give drugs, and so we know this diagnostic algorithm that MASLD, we have to look at the metabolic risk factors, alcohol, and my colleague Dr. Vijay had elaborately told us about MET-ALD. Most patients we know will be simple steatosis, and only a small proportion will be what we call as non-alcoholic steatohepatitis. So a lot of our effort goes in finding NASH, because this is the group of patients which go on to develop liver-related outcomes. Most of the simple steatosis will remain like that, and most of them will have metabolic problems rather than liver-related problems and will require metabolic therapy. So really focus is on finding out NASH, and NASH means both fat, inflammation, and fibrosis. So a lot of tests are designed for fibrosis. So we really are able to assess for fibrosis better than the inflammation. So we know that outcome of NAFLD is the main cause of death is cardiovascular, followed by cancer related deaths, and only third is the liver related deaths. So as I said, only NASH progresses to cirrhosis and HCC. So what are the things that we need to do whenever we come across any patient with fatty liver on ultrasound? We have to rule out and treat other secondary causes. So what are the secondary causes? We know alcohol, hepatitis B and C should be ruled out in all these patients. Other metabolic disorders, as is clinically indicated, may have to be ruled out, like Wilson disease, maybe iron overload, and drugs are important cause, and we should try and exclude drugs as the cause of hepatic steatosis. The second biggest step is really treat the metabolic syndrome, and we will come out in details on that. The main focus is going to be NASH and how do we treat NASH. Now, liver biopsy is the only real way to diagnose NASH, and we know it is steatosis, ballooning, lobular inflammation, and fibrosis goes into NAS score, which defines NASH. Surrogate markers that we commonly use for fibrosis are APRI-FIB4, non-invasive blood-based markers, or FibroScan or RFE scan, which are the elastography tests. Inflammation, as far as concerned, is difficult to predict, but we use liver enzymes, SGPT, SGOT, and just the mere presence of metabolic syndrome will suggest that there is significant inflammation as well. So this is NFS FIB4 score, and these are the various cutoffs that have been suggested by various agencies. And we know FibroScan, which is quite accurate in predicting of fibrosis, and various cutoffs based on disease. So for NAFLD, it will be more than 7.9, which suggests there may be F2, F3 fibrosis, and more than 12.5, which may suggest a possibility of cirrhosis. As far as our national association is concerned, they have come up with this guideline for NAFLD, where you do lifestyle modification for all the patients with fatty liver. In early disease where the fibrosis, the non-invasive scores are less, then you just monitor with lifestyle modification and continue and correction of the morbidities. Whereas if the APRI score of FIB4 suggests fibrosis, this patient will require FibroScan or other liver biopsy maybe, and then these patients, if they have advanced fibrosis, may be considered for pharmacological treatment, which is what the talk would be for this evening. Now, any drug which is going to be used for a metabolic disorder like fatty liver has to have two basic criteria met. One is it should positively impact important endpoints for liver disease, which is mortality, cirrhosis, and HCC. And it should have demonstrated long-term safety over years. And none of the drugs that we have currently actually fulfill these criteria. And we already saw most of the fatty liver disease actually simple steatosis and will not require treatment. So one message that maybe we will go out from this evening is we shouldn't be pressured to prescribe. Most of the fatty liver disease people will not benefit from what if we are giving liver specific fatty liver NAFLD treatment. So let's go to the meat of the talk, and this is a 40-year patient with fatty liver, and we have to categorize for the sake of management based on whether there is comorbidities, which is diabetes mainly, maybe plus minus obesity. Sometimes we see the ALT as an important factor, especially if there is no fibrosis initially, and most important is the fibrosis, so F0, F1. And then we have various choices of drugs that we commonly use. I have only picked up drugs which we commonly use in routine practice. So lifestyle measures, which will be overall in all patients of fatty liver. Some of them patients will require oral hypoglycemic agents. Vitamin E, some of us will be using vitamin E treatment. Semaglutide has been approved for fatty liver. Resmetirom, again a drug which is approved for fatty liver, currently undergoing DCGI or at least recruiting for DCGI trials and in India, but it is available to some of us on compassionate basis, and saroglitazar is the drug that we commonly use for fatty liver. So let us see, this is the patient with fatty liver and has almost no fibrosis, so F0, F1 fibrosis. With a normal ALT or a high ALT, what are the treatment options here? So I have just tick marked according to what I have said, and I let the panel also comment on this. But maybe let me ask Dr. Prem Kumar. Diet therapy is the cornerstone for most of our management. So how do you, maybe know it has to be weight reducing and but it's difficult to manage. What do you do for improving adherence to any of this diet protocol?
So the lifestyle modification, first comes the diet. So diet, we have to go for a hypocaloric diet, which should be 500 to 1000 kilocalories deficit every day. So, and the weight reduction target should be around 5%, 7% and 10%. So 5% reduction of weight is associated with reduction in inflammation
and 7% reduction causes a resolution of the MASH, and 10% reduction usually the fibrosis regression will be there. Usually patient has to be seen every day, and case to case basis the diet has to be suggested for a patient. So the calories should be and diet intake should be advised personally for the patient, and the visits should be at least a 2 weeks once or a monthly once visit, and the patient should be encouraged if there is a weight reduction of 1 kg or 1.5 kg per visit. The patient should be encouraged and should be advised to adhere on the diet, and then the exercise. So 150 to 200 minutes of walking, brisk walking, or cycling or swimming should be advised, along with the resistant exercises for the muscle building.
So as you rightly pointed out, sir, I think the exercise and a diet combination works better than the exercise alone and even diet alone, and it may be easier to maybe adhere to an exercise plus diet protocol. Dr. Radhika, what do you think about changing the diet constituents? People say Mediterranean diet. A lot of these Mediterranean diet, we haven't even seen what the people are eating. They are not natural to us. What do you think about changing the constituents?
Though the guidelines say that the constituents needs to be changed, especially towards a Mediterranean diet, in practicality it is very difficult, especially in South Indian diet. As Sir said, reduce calorie, give a calorie deficit with whatever they are, replace with increased fibers, whatever is available locally, and then increase the protein levels. This works better than completely changing the diet pattern itself, sir. And you had asked about the adherence also. Though we say all these things, initially they will have an thought, 1 week, 10 days, they themselves adhere to all those things. But we need this lifestyle and diet pattern to go on. So we do advise, I personally advise a moral police in the home. Like the younger children. Mostly these people will have a family member who will be monitoring their adherence and will bring the chart to us when they come for the review 2 weekly. So by depicting one daughter or a son, maybe like 10 years, 12 years, they happily do this for their father or the mother. And these people are also morally bound to be responsible for them as an this thing. So they do follow. This adherence becomes better when we have someone at home who is monitoring all these things.
Yeah, that is a very important point. I think when a person goes on diet, the entire family goes on diet as well with him. So essentially everybody has to change practice around that person. But that was an important point that you highlighted. And as Dr. Prem said, that weight loss is the cornerstone, and we should aim to at least have a 5 to 7% weight reduction. More the better, and more weight reduction may improve the fibrosis as well. Some of the other lifestyle changes that can be implemented, and maybe improving the sleep quality, improving the sleep hygiene may also improve the outcome here. Now, sustained weight loss, especially if it is without drugs. Now, this is weight loss which has achieved by GLP-1 agonists as well, and I will come to there. It is better to have a sustained weight loss with diet and exercise protocol rather than with drugs, because if we stop drugs, the people tend to get back they revert back into the liver abnormality much faster as compared to drugs, or as compared to without the drugs. So as far as possible, as much as possible, to have a weight loss which is without the use of drugs. Now some of these patients will be diabetic. Maybe Dr. Ashwin can take this. What is your preferred anti-diabetic, or do you really need to make a choice in a F0, F1 fibrosis stage, which no enzymes are also normal, and the patient is a diabetic? Do you have a preferred anti-diabetic, or can be anything?
Again, now by the latest guidelines, sir, we see whether the patient is obese or not. The obese, they have the ADA guidelines again recommends the GLP-1 itself as one of the first line drugs. So though there is guidelines for MASLD, more than 10 we have to start. We can go ahead with the GLP-1 receptor agonist. That is the new ADA guidelines. All the European guidelines, I hope the sir will tell, has been recommending GLP agonist, one receptor agonist, even if the patient is obese, as a first line drug, So definitely that will be my first line.
So if the person is obese, maybe GLP-1 receptor agonist. If not obese, then is there any choice that you have?
Still data suggests that you can go for GLP, or SGLT2 has an additional effect, especially nowadays cardiovascular effect on SGLT2 is also coming up. Though definite data on the fatty liver is trials are going on, but no specific trials says that it is improving the steatohepatitis or the fibrosis.
Yeah, so with F0, F1 fibrosis is really metabolic disease only, and we need to concentrate on diabetes issue. So maybe Dr. Varun can take this. He's our assistant professor from endocrinology. What are the medical sort of metabolic indications for semaglutide? So I'm not talking about liver related indication, but what do you think will be a good indication for semaglutide?
When somebody with obesity has complications like type 2 diabetes, somebody has obstructive sleep apnea, elevated triglycerides, and the full metabolic complex.
So when you say obesity, is what BMI are you talking about?
Definitely for the Indians, have a BMI more than 25 is obese. A lot of people are not unaware of that. 23 to 25 is overweight, more than 25 is obese. So I would not start upfront, but guidelines say you have to start more than 25. But when somebody has obesity with diabetes, with MASL, with sleep apnea, or with elevated uric acid levels or other metabolic semaglutide. But before that, I would do some screening assessments, what all to be done before we start somebody on semaglutide. So if somebody has a thyroid nodule, the guidelines say somebody having medullary thyroid carcinoma you should not give, but any nodule better to avoid, because you have to biopsy it to an FNA and see what it is. If it comes as AUS, again follow up and do after 3 months, 6 months. So I would say any nodule just leave. Don't worry, because it will again transform into something in the future, and this may be one reason why it would be a malignant transformation. And one more, somebody history of pancreatitis, history of gallstones, definitely you should not use semaglutide. But because it's being used rampantly outside, people in beauty parlors give it, in gyms people give it, they have these packages for bride and bridegrooms given, with some package. So I think guidelines have come up and Indian government is regulating it, but still it is given outside properly. And one more thing is people misses psychiatric illnesses. So there was a study in Australia. In the West, you get it in a department store. You don't have to go to a pharmacy. You just buy semaglutide by ordering in Amazon or something. So people get it, and a lot of people who had underlying psychiatric illness in Australia, a study in December 2025, around 2 million people had worsening of suicidal tendencies. So somebody having a background psychiatric illness, always avoid giving somebody having depression or somebody having schizophrenia, any psychiatric illness. If he's saying okay, if he's not saying also, you have to be cautious and then start before giving it. And again, diabetes also, it's not a blanket statement. Somebody having retinopathy, no, there is no indication, because this can worsen retinopathy. GLPs are known to worsen retinopathy, and there are a few people who have gone blind also after starting semaglutide. We have a phenomenon called as AION. You might be aware of it, non-arterial ischemic optic neuropathy. So somebody having progressive proliferative retinopathy, always do not give semaglutide. These are some things which I would do before I start somebody on GLP. So we have a checklist, and then only then, and I discuss with the patient. Like sir said, they regain weight after some time. So if you stop it, they ask me when do we stop? Yeah, we have robust data of GLP from last 40 years. Lisdexamfetamine came in 1990s. So we have a lot of data from that, but still how long-term complications, like how we have robust for metformin, we don't have anything for GLPs as of now. So what happens after 10 years, 20 years, I don't know. I'm starting a patient on a costly medication. I still don't know what will happen after 20 years when he's on this medication. And if he's asking when to stop, no, guidelines don't say you should not stop it. This is a progressive illness like diabetes. MASL is again a chronic progressive disease, so we don't know when to stop. And if you stop, every month 0.4 kgs are increased, and After 1.7 years, they go back to their normal weight, how they were before starting the medication, and the HbA1c again shoots up to the previous weight, and all the other things again go back to normal. So I spend around 20-30 minutes for every patient before I start them on GLP. So these are some things which you must be knowing before you start somebody on GLP.
Sure. Thanks. Thank you, Dr. Varun, to highlight certain criteria before we start GLP. And maybe in this stage, usual molecule which we are familiar with, metformin, will be as useful in control of diabetes. So this is the EASL guidelines, which says the preferred pharmacological treatment options for treating comorbidities, at least in F0, F1, where we don't have a liver indication, metformin still remains fairly there as an option. Maybe Dr. Vamsidhar, and can you take on the statins with raised ALT? Of course, I haven't told you very high ALT, but say in fatty liver level ALT, how would you manage your statins? And
previously there's a notion that statins can cause an elevated ALT, but in practice per se, statins will not cause so much rise in the ALT. It's a metabolic factors which will cause most of the things. Even the patients who are on statins, the elevated ALT we are not seeing in the follow-ups of the OPD, but we get a frequent reference from the cardiologist whether we can continue on any patient of MASH. But even the simvastatin also we are using in the patients, reducing the fibrosis also. So I don't think currently we should not stop statins in a patient of obesity with cardiovascular risk, all these things. I think we have to continue statins as prescribed by the cardiologist.
yeah, thank you, Dr. Vamsidhar. That is what I think would be the ideal way. Here, the metabolic disease takes priority, and if there is indication for statins, there is no reason for us to hold back statins most of the times. And how frequently do we follow up this patient? What do you think, Dr. Prem? How will you ask him? F0, F1 fibrosis, nothing much there right now?
Usually the patient should be followed every month with the metabolic parameters, and the weight has to be assessed every month.
So yeah, so it will be metabolic parameter related follow-up, and it will be not liver mainly, maybe metabolic disease parameters. And this is one data on use of, as Dr. Ashwin pointed out, about SGLT2 inhibitor, where they have looked at a huge database of 19,000 and compared with non-SGLT2 inhibitors, and they have shown that there is increased survival, decreased cardiovascular events, and decreased progression to advanced liver disease. So there may be some data which is coming up. How do we select anti-diabetics in this group of patients? It is very preliminary, but again, the thing would be to control diabetes. Maybe just a quick comment on if there is no comorbidity, patient is not diabetic, patient is not obese, how would you manage this lean NAFLD, and is there a HCC surveillance need? Maybe Dr. Radhika can take this.
So when there is no cardiometabolic risk factors, no obesity, only fat in the liver which we need to target, we have fatty liver, that is liver targeted therapy, resmetirom, that is not widely available here, but that is supposed to reduce the fat, inflammation and progression of fibrosis also. In these patients with lean MASH, we will be happy to choose only the liver targeted therapy of resmetirom.
So maybe F0, F1 fibrosis, I am not sure whether we would, currently all the trials are saying F2, F3 fibrosis. So F0, F1 fibrosis, only simple steatosis may not be the target of our liver related therapy. Maybe this patient will just be healthy lifestyle, exercise, diet, and keep on follow-up would be, and this person may develop a metabolic syndrome or is prone to develop a metabolic syndrome in future. So maybe we can look at that way. So this is the main focus of the talk, and this is F2, F3 fibrosis. Patient and here the ALT really won't matter too much, and we are only looking at the fibrosis, and we are looking at the comorbidities. We are looking at obesity, diabetes, and if there is no obesity or no diabetes. So lean NAFLD with some fibrosis. As I said, there will be lifestyle measures in all. We will in a diabetic patient, we will use oral hypoglycemic agents. Then there are various options that we have. So maybe Dr. Vamsidhar can take this. Are you comfortable with what I had ticked? Because these are various options, and we will come into it. That in obese patient you can possibly use semaglutide, maybe resmetirom, saroglitazar, whereas in diabetic patient you can use semaglutide, whereas other things like resmetirom is more like ma'am pointed out is in lean NAFLD. So let me just go into this. Diabetic with NASH, F2, F3. Dr. Vamsidhar, what would be your drug of choice here? Diabetic with NASH.
So I think, see, basically we have to control the metabolic traits, and also when we come to the drugs, I think lifestyle modification, also semaglutide may be the best option. But because the grades of fibrosis is still it is on studies only. Resmetirom has a good effect on F2, F3 fibrosis. I think either combination of like either semaglutide versus the resmetirom may be the best options. Maybe.
Okay, so let me just categorize the pharmacotherapy that is currently available for MASLD. It is either liver targeted therapy or it is a comorbidity optimized therapy. So it could be directed to the liver, where it is more likely resmetirom and some data to suggest semaglutide. But if it is comorbidity related, so you are aiming for weight loss, you are aiming for glycemic control and reducing the cardiovascular events as a whole. So in this group of things will come GLP-1 and SGLT2 inhibitors as well. So these are the two ways to look at the therapy, and currently these are the therapies that are available to us, and most of us will be using it: resmetirom, semaglutide, GLP-1, other ones. And if you can look at the categories, except for resmetirom, which is MASH targeted, semaglutide, saroglitazar may have a combined effect on MASH and systemic therapy as well. The SGLT2 inhibitors or pioglitazone is more a comorbidity related therapy. Most of them are used for F2, F3 fibrosis. Saroglitazar is approved in India. The resmetirom and semaglutide are approved across the world for NASH. So just a few slides on various therapy. Vitamin E, we have a meta-analysis showing there is improvement in NASH score and around 400 to 800 mg per day. Dr. Ashwin, maybe, do you use vitamin E in your practice, and when do you use it?
So mainly backed from the prevents data. I use mainly when the patient is having high hepatitis, sir. When the CAP score is high, when there is an indication for management, despite there is no improvement with the lifestyle modification, we have from the Bilal data, when we combine the saroglitazar with the vitamin E, there is improvement of both steatohepatitis and fibrosis, improvement of LFT levels, improvement of triglycerides level, and also the glucose levels are improving. So in that circumstance, I use along with the saroglitazar.
Yeah. So what we have found is it does decrease SGPT. So as you rightly pointed out, inflammation part of it is important. So we tend to use vitamin E in a subgroup of patients where there is high SGPT along with that. About saroglitazar, maybe Dr. Prem Kumar. There are multiple real life studies from India. There is a phase 2 trial, a very small number of patients which showed some improvement in fibrosis as well in serial biopsies, but again only a small database. Do you use saroglitazar, and what subgroup do you use for?
So we use usually previously we used to use in diabetic patients with dyslipidemia and steatosis. We used to use saroglitazar. Nowadays we in non-diabetic as well as all the other patients, we started using saroglitazar after seeing these data. So other than that, we use vitamin E in a non-diabetic individuals and alongside the diet and exercise.
Yeah. So the data is very limited amount of time as well, usage. So we tend to use it for F2, F3 fibrosis as you had suggested in our practice as well, Saroglata sir. Resmetirom, Dr. Radhika, do you have any experience with resmetirom? This is a trial which is a registration trial, Maestro NASH trial, 966 patients, again only 52 weeks outcome, but what is shown as NASH resolution quite significantly higher, and there is some amount of fibrosis reduction as well, maybe lesser than NASH resolution, but there is some amount of fibrosis reduction over a period of 52 weeks. These are all F2, F3 fibrosis to start with. As we know, it is a liver selective thyroid hormone beta agonist, and so it has got a liver specific action and it's not dependent on the comorbidities. So do you have any experience with resmetirom?
Sir, resmetirom has been approved by FDA, but it is not widely available in India. But in selected cases, after counseling, we do have arranged resmetirom for few cases, and a couple of like 5 to 6 cases are currently on resmetirom under my care, sir. And we do select this medicine, as, like you said, only for those patients where the fat and inflammation and fibrosis are the problem, who does not have much of cardiometabolic risk factors.
And Dr. Varun, maybe, Dr. Vamsidhar, maybe you can say what where will you do resmetirom, and if you have used, if there are any side effects, what you have found out?
I have not used resmetirom, sir, but will be generally by the theory goes like in the F2, F3 fibrosis will be used, but in cirrhosis still trials are going on.
So F2, F3 fibrosis, yes, it has been used, and we tend to get it on a compassionate basis currently, and we found it quite easy to give, so not much of side effects, and serially we did find improvement in fibrosis scores as well. Do you consider liver biopsy before starting any of these therapy, Dr. Radhika?
Though we had considered, but we have not done, because counseling the patients to take this medicine, which we specifically bring it out of way for them itself, is becoming a big issue. So getting them to do a biopsy was not feasible for us, sir.
Yeah, so I don't think we also ask for a liver biopsy for a day-to-day practice as such, and long-term impact of resmetirom, whether it can be used in cirrhosis or any other THR beta agonist, they are all under study currently. Semaglutide, and this is what Dr. Varun has sort of made us aware of various problems as well, and this is the trial which has interim data, which is 72 weeks of data published, and which showed improvement in steatohepatitis, which was far better than the placebo, and there is a definite reduction in fibrosis, much lesser than the inflammation, but still a 10-point reduction in fibrosis over a 72-week period of semaglutide giving subcutaneously every week. So all of them have F2, F3 fibrosis to start with. So maybe all of us can just give us our experience with semaglutide. How easy was it to use if you have used? Dr. Ashwin, maybe you can start.
Personal experience means, sir, I also work in one of the highest diabetic center, Mohan Diabetes, where they start itself with the GLP-1 and GLP-1 receptor agonist. So for them the counseling is more easy, and especially most patients will be on insulin. So for them the compliance and adherence will be easy. Regardless, at a hepatologist point of view, when we start, the patients are more non-compliant, or they have little refrain.
So if it is a diabetic person, it's easy to give. If it is non-diabetic, it will be difficult.
And when a patient obese patient coming to you, they have tried the non-pharmacological medications, and they are knowing that there is another opportunity with grade 2 fibrosis. There are guideline is more than 10 up to 20 without any portal hypertension. Then platelets more than 140. Then we counsel for the GLP-1. And if you are aiming a little higher weight loss of 15 to 20%, then we go better for the dual tirzepatide.
So just what we found is quite a bit of side effects, GI side effects in these patients. Adherence will be a problem in long run. I am not sure whether oral preparations are going to solve any of our problems. May not get the desired weight loss. Primarily we need a weight loss because we are targeting weight loss here, and whether it will regain definitely after stopping therapy. Somewhere we may have to stop therapy. If it's not a diabetic patient, we may end up stopping the therapy as well. I have no personal experience of seeing muscle loss, but that has been described in F2, F3 or advanced fibrosis as well, that there is inadvertent sarcopenia developing in these patients with GLP-1 receptors. So various other problems that can be used, and maybe Dr. Prem, you want to comment on this?
In Madras Medical College, we have both vitamin E as well as the saraglitazar in supply. So we use both the drugs for the patients with steatohepatitis. In private setup, actually patients with morbid obesity and fatty liver, they come to us directly and ask for the weight loss agents, saying particular brand, and ask for it, and they are very complaint for the drug. So as a lot of VIPs have lost their weight, and it has been shown in some of the TVs and other things, they come for particularly for that particular drug, and they want to start the drug, and they are compliant with the drugs.
So if they are asking for it, they will be compliant. But if we are telling, maybe they are not that compliant with the drugs. Yes. So as in any disease, there is a continuum of care, and maybe initially when there is only steatosis and inflammation, we are looking at resolution of MASH, then reduction in progression of fibrosis, and in advanced stages we are really looking at reversal of anti-fibrosis. So a lot of these drugs are put into brackets, but most of them are currently in untested areas, and any pharmacotherapeutics, we have looked at weight loss pharmacotherapeutics, maybe GLP-1, because that is what is available easily and is approved for NASH currently. There are dual triple agonists, and I'm not going to detail, maybe Varun can advise us regarding that. And there are other metabolic modulators which have not yet come into market, like FGF21, so which are promising results, but I'm not going to detail with that part as well. As the time progresses, maybe as the data evolves, we may be able to target multiple pathways in a single patient. So Dr. Varun has already spoken about what are the points to consider against a wider use of semaglutide. Maybe a couple of lines on oral semaglutide and tirzepatide.
So oral semaglutide is available, and it's been generic from last quarter of after March. It become generic, and it's freely available and with a less expensive cost effective thing. So oral is there. Previously we just had one brand which was from the patent company, and now we have a lot of generics. Oral sema can be given we had a couple of patients in our fatty liver clinic in last month who had syncope after injectable semaglutide. So we had to switch them to oral, and we put them in very minimal doses. But one thing I can say is oral comes in 3, 7 and 14. So to achieve the full therapeutic effect, a head-to-head comparison between injectable and oral, you must have at least 50 mg is what is equal to 2.4, but effect starts by 7 mg or 14 mg. So oral is you have to take an empty stomach, and it should be taken with only half glass of water, 80 ml of water, not beyond that, because it works on a principle called a snack. SNAC is a permissive absorption, transient permission absorption, where it will absorb with an alkaline pH. So if you take a lot of water, if you use a PPI, it will not work. So that is something you have to deal with oral, and it would be in fasting set 2 hours spacing. somebody on thyroxine, somebody on any other medication, there should be spacing should be addressed properly. And GI adverse effects of more with oral compared to injectable is what we have seen. People come with vomiting, bloating with oral. One more oral GLP which is going to come up, which has already made news in trials, is orforglipron. You might be knowing about it. So that will be launched next year. I mean, that is a non-peptide GLP that can be taken any time of the day, and that is does not require any fasting or anything. It is better GI tolerated. We'll just wait and see in 27 what happens to orforglipron, but it's very expensive is what the trials are saying. So yeah, oral can be a good alternative for injectable in people who cannot tolerate, who have needle phobia. So we use oral in few patients from us.
And what about tirzepatide? Where do you say we are aiming for weight loss?
Yes.
So should we say semaglutide versus tirzepatide? What do you think?
Yeah,
The data on tirzepatide in liver is not yet there. It's not approved for liver indication, but for obesity.
So yeah, for NASH is there in phase 2. It has not yet come to phase 3. So basic target is more weight loss is seen with tirzepatide compared to semaglutide. Tirzepatide is a combined GLP and GIP agonist. So it blocks more of GIP. That's why the GI side effects are less. But one thing is cardiovascular safety is not proven with tirzepatide. Semaglutide has a lot of cardiovascular safety. Semaglutide has a lot of renal benefits. Semaglutide has a lot of other benefits as well, the OSA. So I mean, head-to-head long-term cardiometabolic benefits are more with semaglutide, but weight loss and the other OSA, everything is more with tirzepatide. So if you want targeting acute weight loss, somebody morbidly obese, unable to BMI extremely high, there are people who have lost about 25 kgs on tirzepatide. So I mean, for targeting weight loss alone, I would say tirzepatide. But I mean, more the weight loss, more the sarcopenia. So 40% sarcopenia seen in tirzepatide, 30% semaglutide. So I mean, encourage them to have high protein in their meal. So at least 1 gram per kg body weight. So and 1/3 of it in the breakfast alone. So 30 grams protein should be taken in breakfast alone is something you have to tell. Along with lifestyle and diet, more proteins in the diet is something you have to say. So tirzepatide is more for weight loss, but cardiovascular benefit and renal benefit is more in semaglutide as per the data what it says.
Thanks, Dr. Varun. Now we just move on to the F4 fibrosis, which is cirrhotic range. Now, patient can be compensated, maybe comorbidities, and maybe decompensated. Maybe Dr. Radhika, when the patient has compensated cirrhosis, do you think you want to target MASH targeted therapy, or is it only for maybe diabetes control? Are you comfortable in using MASH targeted therapy in cirrhotic liver currently?
Any F4 fibrosis or advanced fibrosis with cirrhosis, none of the MASH targeted therapy are approved. So we just continue with lifestyle modifications and other medications. But still ESL says that these drugs, MASH, this GLP-1 agonist can be used for cardiometabolic risk factors and not as a MASH targeted therapy. That can be clearly explained to the patients, and then we can start and see, though it is not being properly endorsed.
Yeah, so this is one such data. It is not yet approved for F4 fibrosis or cirrhosis, and this is these are all upcoming data on safety of all these agents in MASH cirrhosis as well. And this study looked at a large database in a PSM matched population, almost 6 lakh population of diabetes with NAFLD, and they looked at major adverse liver outcomes, and they saw that semaglutide is associated with lower major liver outcomes as compared to other diabetic drugs. So maybe semaglutide can be used even in advanced liver disease, but we don't yet have the data, and people have started using maybe in clinical practice more than the trials. So this is one small study that they had done in double-blind randomized trial in NASH cirrhosis, where they have used semaglutide, but they looked at improvement in fibrosis over a certain small amount of period, and they didn't find any significant benefit. Actually, placebo had more decrease in fibrosis by single point than semaglutide. So it may not improve fibrosis, it may improve liver related outcomes by controlling of other comorbidities. So the jury is still out whether it will be useful, And as far as decompensated cirrhosis is concerned, none of these therapy I would say are safe enough to be given at that point of time, and maybe anti-diabetic would be insulin as we usually will. So the trials are 1 to 2 years, 3 years maximum, but it's a fast evolving field to say the least. So we will maybe summarize here, and we should triage with NITs. We don't usually triage with biopsy, and we select patients with F2, F3 for targeted therapies, and the targeted therapies are really GLP-1, saroglitazar, maybe SGLT2, resmetirom, and we respect the F4 or liver cirrhosis boundary where we don't use MASH targeted therapy anymore. So thank you, and we can take questions.
What a treat actually, visual, it's an oral treat. But one thing, I have 2 or 3 questions before going to the audience. You said 25 and above is obese. In India, they say 25 is reduced to 23, 23, 28 say overweight, then becomes 28. But you say from 28 itself obese, or 25 is obese starts.
Asia Pacific guidelines is what we follow, sir, in Endocrinology Society of India. So more than 25 is overweight. 23 to 25 is overweight, more than 25 is obese. So 20 to 25 is overweight, more than 25 is obese. And obesity we classify into stage 1, 2 and 3. 25 to 30 is 1, 30 to 35 is 2 and more than 35 is 3. But however, if somebody is having obesity with complications like quality of life, having osteoarthritis or diabetes, everything, so we have Edmonton obesity staging system that has 1, 2, 3 and 4. So if somebody is having sleep apnea, he will go to stage 2 directly, even the BMI is 24. So based on the complications, we again classify obesity as per EOSS into 1, 2, 3 and 4. So
want to moderate resmetirom. Before starting, we have to we have to rule out hyperthyroidism or hypothyroidism, because this causes intrahepatic hyperthyroidism. They say the term is called intrahepatic hyperthyroidism. So we should be very careful.
Yeah.
80 or 60, they say it is available in Chennai. I have seen some prescriptions with the 80 milligram tablets. Doctor not started. This point I want to know. Third thing, at least I'm happy to say you have acknowledged the role of gallbladder disease. In one of the diabetic comes, I asked, no, that is only an anecdotal report, they refused my claim. But what about the gallbladder disease? Definitely semaglutide is problematic. It is problematic. And the diarrhea, is it local effect or general effect?
more of a local effect, sir.
Local
effect,
effect,
yes.
That's it actually. We can't use any drugs. What are the drugs you use for that? Whether they get over it, they get solved or not?
Yes, we start in very low dose. I mean, the guidelines say
2.4,
yeah, 0.25. So we start at 0.25,
okay.
and then after 4 weeks we see. And some people even we go even slow. They have diabetes autonomic dysfunction, so we don't go up to 0.5 also. We go even slow. The guidelines say scale up every 4 weeks. 0.25, 0.5, 1, 2 and 2.4. But we go very slow. We personalize the management based on the patient's requirements. And there are some people who lose weight on 0.25 itself. So and then we go up to 0.5 and then we maintain. Only if he has a plateau, that is no weight loss after some 2-3 months, only then we escalate to 1 or something. So we are happy with giving micro dosing and having some minimal weight loss rather than escalating so fast, and because intolerance is very bad. People come with 20 episodes of diarrhea and also that is very bad.
And is it safe in kidney problem?
Yes, sir. I think EGFR more than
in
30.
some dehydration kidney problem, it worsens, they say. I am reading an article from Mastro on NASH and the outcomes of NASH. They got STEPS therapy. STEP means steatosis, transient elastography, exclude the things. In they say it is difficult. Sometimes kidney problem can worsen with semaglutide. Semaglutide is freely used. So we will only see the post-marketing surveillance, we will only see the adverse effects. So far what we see is the pre-marketing. Post-marketing we will see more of the adverse effects.
For diabetes we have been using it, sir. So for proteinuria it's been beneficial, like how SGLT2 is being beneficial. Proteinuria we can use, but again CKD stage 4 we should be very cautious when we use these.
Is there other anti-SGLP1 as well being tried in India? So I know multiple trials are currently going on with various molecules in India which are GLP-1, and is the retinal side effect as well, which is quite significant.
Yes, some some people go blind. I mean, even having a normal fundus, we usually check fundus before we give GLP. So there's one thing, cup disc ratio. I mean, cup disc ratio, if it's low, they have more chance of developing blindness. Some people, even with a normal ratio, will have blindness. That's an autoimmune phenomenon which nobody can do anything about it. So I mean, very rarely discussed, but we have to have a look at the fundus before we start GLP.
Sure. Anything, any other audience?
Just a couple of practical issues. Various illnesses, we all the time talk about diet and exercise. Practically, it's a fiction, it never works. And, I usually tell people about exercise, diet, and the rest. I tell them walking is good for you, walking away from the dining table is much better. And with the arrival of semaglutide, it has become more difficult. People don't even want to listen to diet or exercise or any of your preaching. They want medication. And I think a couple of issues, it really works in the majority of people. Majority of people tolerate very well. And obesity is an illness, so just like we treat hypertension, they have to be on the medication long term. And there are certain other benefits we see also. Alcohol intake goes down when people are on semaglutide. So I think that kind of helps with the liver disease also. I think we got a lot of things to learn, but I think definitely things are changing with the availability of these drugs.
So I will comment here maybe before the panelists say anything, that diet and exercise are an useful adjunct for any management, because that is what will keep them coming and keep them motivated. But again, I get your point. We may not get the weight loss or the desired effect or even a sustained effect with all this, and I am not sure how good or better the drugs will behave. We don't have the data to say how better the drugs will be in a longer period of time, or will they be adjusting to the drugs as well and go back to the routine, the usual weight that we had. That I'm not sure about what would happen with that drugs. Maybe Dr. Radhika or Dr. Ram, Dr. Prem Kumar may want to comment on this.
Actually, if you tell about, counsel the patient about the side effect profiles, probably they will not start the medications, and they will strictly adhere to the diet and exercise rather than going for GLP-1 or this tirzepatide.
I don't think we have to be very scared of the drugs, but we have to be judicious in our usage. If we say more than 25, most of us in this room will be more than 25 BMI. Then I wouldn't be happy taking a GLP-1 for lifelong.
Difficult, they say. Although pioglitazone causes weight gain, it is not deleterious, they say.
I didn't touch pioglitazone because most of us may not be very comfortable in using it. Weight gain is mainly because of pedal edema and fluid rather than the fat. But once a person who has come with fatty liver gains weight, it becomes difficult for them to comply and really say that it is beneficial.
Suppose we have a diabetic patient who is well controlled on conventional anti-diabetic drugs, is found to have, let us say, an advanced fibrosis when he comes for his follow-up. Do we have enough evidence or data to suggest that we move to these new drugs right now, let us say both metabolic as well as that liver-focused medicines? Suppose who's well controlled. Suppose someone is not controlled, I can understand that we move from one to another.
Yes, so I don't know the answer, and I'm pretty sure none of us will that specific question, whether you need to change therapy once you diagnose F2, F3 fibrosis in a patient who is well controlled diabetic. I am not sure whether endocrine people will change, but the data, what the trials are, resmetirom or semaglutide are on F2, F3 fibrosis, and some of them would be on other anti-diabetics. So they have said in addition to that, so it may be that they may prove beneficial for liver-related side effects, but I don't know the correct answer yet. Maybe Dr. Varun can also say what he thinks.
So the ADA guidelines say we have to go from a glucose-centric to a cardiometabolic-centric guideline. So I mean, he's established organ failure like MAFL. So you have to switch to I mean, you have an option of switching to SGLT2 or GLP. So I mean, if he's well under control, what medication he's on is something very important. If he's on sulfonylureas, I think they offer no additional benefit. So I think probably you can stop it and switch to a SGLT2 or a GLP. If he's on gliptins, I mean, gliptins are nothing but they inhibit your DPP4, which is a GLP inactivator. I mean, metabolism of GLP. So we can stop the gliptin. Gliptin is very, it's like an ant in front of a GLP. So I think you can stop a DPP4 when somebody is on, start on GLP, and glimepiride, sulfonylureas, you can always come down on it. So I think metformin is still the cornerstone. You have to continue metformin. Probably look at the organ failure as a whole and discuss with the patient, and you can change. So that is something.
In our practice, generally, I would say metformin is a very good drug that we have found useful, and long-term data, safety, and positive outcomes are quite proven with metformin. So I would want to continue metformin. Other drugs, as he suggested, maybe the trials also had these group of patients. So I would think maybe using this.
Okay, thank you, moderator, as well as our panelists. I think my final word will be NAFLD is a multi-system disease, and we have to prepare ourselves to tackle it in a multidisciplinary way rather than whether the hepatologist or diabetologist or endocrinologist. It should be, the approach should be a multidisciplinary one. Thank you, one and all.
Thank you, chairpersons and esteemed panelists. We really had a very good time, particularly the panel discussion. It's a difficult topic. It was made very easy and understandable. We all understand with the newer medicines, it's going to be a difficult part. Semaglutide is available everywhere, and many of the practitioners are starting from right, left. So we have to see what happens in the future. So this discussion has given a good idea on what we had. Today we had a very good knowledge-packed sessions on PG's panel discussion and the CME as well. I thank all the participants, the consultants and their colleagues for this. And now I will request Dr. Thaimanavan sir to come and felicitate our guest faculty from CMC Vellore, Dr. Varun. Please come forward, sir. Thank you, Dr. Varun. And I would like to thank TNSG, Patton, Secretary and the office bearers for making this event possible, and particularly Zydus and Residency Towers for providing this accommodation to make the CME success. And I'll thank all the participants, postgraduates who has made their time to attend. So we'll meet the next month as usual, the last Saturday. And I'd like to invite you all for an cocktail dinner. So people with fatty liver, be caution. You have cocktail and then high caloric dinner, so be caution. Thank you all. We'll meet next month. Thank you.